A very good evening to all. A warm welcome again to the Indian Cardiology Summit 2021, Day 3. I'm Dr. Shafeeq Mattummal, consultant and interventional cardiologist in ASTMIMS in Calicut. We had, in the first 2 days of summit, exciting sessions in coronary imaging and interventions. We had excellent live cases which actually generated a lot of educative discussions and evidences topped up by imaging. The lectures brought in contemporary evidence-based practice as well as future directions, and case-based presentations created a lot of interest, and all discussions were to the point. Both the international and national speakers and the panelists did a wonderful job. Today, on day 3 and the final day of the summit, we have dedicated symposium in structural intervention, which is actually the highlight of the summit. There will be a live case. We'll start with a live case and case-based lectures in valvular interventions with tips and tricks. There is a dedicated session for intervention for stroke prevention. And in the final session of the summit, there will be keynote lecture in TAVI by Professor Lars Sondergaard from Copenhagen. So guys, to roll out the program, I invite today's moderators, Dr. Anil Salim and Dr. Salman Salahuddin, to take over. Thank you.
Hello, thank you, Dr. Shafeeq. Good evening, ladies and gentlemen, teachers, colleagues, and friends. Welcome to day 3, the ultimate day of Indian Cardiology Summit. Today promises to be a very exciting day. We are going to be dealing with structural interventions, as Dr. Shafeeq mentioned. We are going to kick off today's programs with a live case from ASTMIMS Calicut. I'd like my colleague and co-moderator, Dr. Anil Salim, who will introduce our expert panelists for today.
For this live session, I would like to invite the expert panelist, Dr. Edwin Francis, who is the Senior Consultant and Chief Pediatric Cardiologist, Lisu Hospital, Cochin, and Dr. Rajashekhar Verma, Senior Consultant Cardiologist, Aster Medicity, Cochin, and Dr. Vijay Samuel Thompson, Professor and Head of the Department of Cardiology, Christian Medical College, Velu, and Dr. Anmol Sonavane, Senior Consultant Interventional and Structural Cardiologist from Mumbai. Welcome to you all.
A warm welcome to all our expert panelists there. We will push off directly for our live case. Our live case is going to be telecast from ASTMIMS Calicut from Kerala, South India. The chief operator for today would be our course director for today also, and the program coordinator of this summit, Dr. Shafeeq Mattummal. A few words about Dr. Shafeeq Mattummal, is senior interventional cardiologist and chief of cardiology at ASTMIMS Calicut. He carries with him more than 15 years of expertise in interventional cardiology. Trained and a fellow from Bern in Switzerland. Today he's going to run through us on his live case, I believe, on PFO closure. Without further ado, I'll give you the mic, Dr. Shafeeq, over to you.
Thank you, Dr. Salman. I hope I'm audible.
Yes, indeed. Yes. Fantastic. Carry on.
Good evening, everyone. Greetings from ASTMIMS Cardiology. I can see Dr. Anmol, Dr. Edwin, Dr. Vijay, and Dr. Verma. Good evening.
Hi.
Okay, so we have planned PFO device closure for today. So this is a young lady who's 43 years old who sustained a stroke, left MCA territory stroke in March of 2021. Can I have the presentation transmitted, please?
Yes.
So she had a major MCA territory stroke with an M1 occlusion. She was thrombolized with alteplase in another center. There was no adequate reperfusion clinically, and she was transferred in our center, and mechanical thrombectomy was done within hours. Over a period of time, she improved with physiotherapy, and meanwhile, we continued our workup. There was no conventional risk factors, atherosclerotic risk factors, and there was no family history, and extensive evaluation was done for the young stroke. As a part of it, our stroke unit performed a transcranial Doppler, and that showed significant hits bilaterally. Can you go to the next slide, please?
Next.
The electrocardiogram was normal.
Next.
There was no atrial fibrillation documented in a Holter. and structurally she had a normal heart. Next slide, please.
Next.
This is the rope score. So the score was 7. Next slide, please.
Next.
This was the transcranial Doppler showing hit in both MCA during bubble contrast injection. Next slide, please. So she was taken up for a transesophageal echo. As you can see, there is a tunnel and a PFO slightly more cranial. Can you go to the next slide, please?
Next.
So on the right panel, you can see okay, next slide, please.
Next.
So that was the bubble contrast coming, demonstrating right-left shunt. Next slide, please.
Next.
So these were the measurements. The defect had a dia of 2.3 to 2.5. The length of the tunnel was around 11, and the distance from aorta was around 9 millimeter. So I leave it to the panelists for the discussion. What would be Dr. Edwin, Dr. Vijay?
Thanks, Shafeeq. Nice images and good demonstration. Did you do a Valsalva? Because technically, from your shunt, this doesn't look very severe. But I presume the defect size is more than to qualifies for a large defect. And if you had done a Valsalva, unless the patient was uncooperative, I'm sure the shunt would have been much more than what you've actually seen.
She was recovering from the hemiplegia, and she could not actually do that.
Good case. I think you should go ahead. I mean, see, your defect size 9 millimeters qualifies for probably the smallest defect, smallest size device. And 9 millimeter you said from the aorta. What is the distance from the SVC?
6 m.
So 6 is a bit too small, you know. Normally you need to have at least half of the device size should be able to accommodate. But maybe you can do the T once more. I'm sure it looks more than 9 because
no, from the SVC it is actually 12 mm.
That sounds right. That sounds
from
right.
Just my opinion. I stopped taking these measurements for quite some time. Maybe I may be wrong, but then since my experience with regular AST devices, in which most of these Western data say dimensions of like this is mandatory, and total septal length, which I've never ever done for the last probably more than 10 years. That's what I never had any major problems. So I'm not very sure about these dimensions they mention on these, say 10 mm from here. So it should have some rationale, but somehow I haven't found it very useful. I don't want to know other panelists, what do they feel about these measurements.
Edwin, how do you go about then?
Dr. Edwin, how would you go about sizing for a PFO is what Dr. Shafeeq mentioned.
I mean, sizing is a measurement on the T as you showed. I'm saying about the measurement, the distance from the adjacent structures. The absolute measurements, if it is, say, as you said, it's 2 or 3, I may put the smallest PFO device available, 18. But agreed, if there is a good septal aneurysm, like if it's a large septal aneurysm moving to and fro, then I may change the size of the devices, may increase the size of the device.
I think what Dr. Vijay mentioned was you need to at least have half the disc diameter away from the aorta and the SVC is what he probably meant.
That's what the literature says. I just want to see the others' opinion that I don't usually follow that. And
correct.
Maybe I'm lucky to have not got into trouble, but I don't want to see the others' opinion, that's all.
Dr. Anmol, you have any insights to offer?
No, I agree with Dr. Vijay, whatever he said. The lesion should be at least half the size. And this patient is young and had a stroke clinical manifestation. I think he is very much suitable for this. That is the only finding what we got for the paradoxical stroke in this patient. So I think.
What would be the to Dr. Vijay and Dr. Edwin the utility of lower limb? There are people who advocate that doing bubble from the lower limb veins in case you don't get this thing. So how often would we need that in clinical practice?
maybe I do 10 Ts, maybe two or three, which I feel there is very strong suspicion. Probably if still bubble is negative, I go ahead and do a femoral with a Valsalva. If that is negative, I won't pursue further.
Dr.
So
Varma,
basically,
any comments?
Yeah, I think this is a very good indication for a PFO device closure in
Yeah.
a young patient with no other risk factors and a clearly demonstrable PFO have been
So,
well shown in trials to prevent the recurrence of stroke. So, yeah, good indication. And as Dr. Edwin said, yeah, if you have a true PFO, generally the other rims and other diameter other than the absolute sides of the PFO, the other measurements generally fall into place most of the time rather than not. So, and if it's not, then it's very, I mean, very obvious once you do the TE that you don't have adequate rims. So I think absolute
Maybe,
measurements, yeah, we don't always do.
it's
okay.
a bit
So
controversial statement I made.
can you rush through what we have done so far?
Yeah.
So just before we...
Before that, just a word, how do you try to cross the PFO? That sometimes a few colleagues, some people ask me there's difficulty in crossing
I'll show
PFO.
that.
Yeah, that's really good for
I'll
the...
show that. So actually, there are many methods to cross the
Yeah.
PFO. So we can have this catheter method, we can have this wire method. I am comfortable with the JR catheter with the Terumo, but I have used multi-purpose in some patients to cross the PFO. You can actually give a bend to the O3A, our regular PTFE wire, just like a multi-purpose, and then go with wire alone. In some PFOs lets in, and there are many methods. Some people just go with the multi-purpose catheter. Sometimes a pressure attached, so you can realize whether you have entered LA when the pressure is there. So we went with the JR with the Terumo, as you can see. Next, please.
Dr. Edwin, you had some tips in crossing?
Yeah, basically, I just find it quite easy. If any trouble for anyone, you keep it from the IVC at the wire alone, let it slide through the atrial septum.
Through the P.
It just walks through it, because if you have a catheter, when come down from the SVC, like we are used to do a PTMC, unlike that case, here it is going to touch the septum secondum. But if you just keep a URC or MPA, the IVC, and let the thermo just slide through the IAS, it just slips it, because it's a blood from the IVC is being directed to the LA embryologically. So
embryologically,
from the
it's in
IVC,
line, correct.
I find it somehow easy. Maybe again, you should try.
So right now, what I'm doing is actually it's extremely important to prevent air embolism at this stage. So we take the dilator very slowly, keeping the wire there initially. And I always keep this end of the dilator catheter. Can you show my hands, please? I actually keep it below the level of the heart of the patient, so that there is less chance of, and I always keep initially the wire till there, so that just don't jam the pulmonary vein, and so that the blood, once the blood flow starts from the sheath, then I bring into the field. So that's just some extra cautious step. We have had a couple of times transient ST elevation in the initial part of our program during this step. So it's extremely important to keep that.
Again, sorry, I again modified my method. In ASD, I just de-air it in the IVC RA junction, and then slide the sheath alone into the LA, so that any air at all, if it goes in, goes up pulmonary artery. In the case of PFO, it may be better to go all the way in, because you make sure that sheath goes through it into the LA, and then come back. I probably keep the wire there in the pulmonary vein, come back in the IVC RA junction, de-air it, flush it well, and then slide it back into. So there is absolutely no chance of any air embolism.
Yeah, I think different people have different techniques. I use a pressurized saline, and just like what Edwin said, I take the dilator out in the IVC, and it's get a clear flush, and just slide the sheath alone over the wire. that works fine. And like crossing also, I agree with Edwin. Most of the time, the wire sort of finds it. Unless you have a very long tunnel, or it's a serpiginous tunnel when you use multiple catheters. And sometimes when I used to change the catheters, I used a straight tip turbo wire. So these are small techniques, like in a series of around 30 patients, what we have found useful.
Great
Good.
tips from our experts here. Dr. Shafeeq, we have Dr. Charanjit Rihal who has joined us for this discussion.
Excellent. Welcome, Dr. Rihal.
Hello, good morning.
Good morning.
Good morning. Nice to see everyone.
We are evening here.
Nice to see you.
Oh, yes.
We have a live session going on here.
Yeah.
So we're in the
Please
live.
continue.
Yeah,
Please
we're in the live
continue.
case here. It's a PFO closure. Dr. Shafeeq has crossed the defect and has introduced his sheath. That's where we have just reached. A warm welcome to you, Dr. Rihal.
Warm. Thank you. Thank you very much.
So what device we have decided upon now? So go.
Dr. Shafeeq,
18?
okay, 18.
What? Yeah.
An
what
18
device,
millimeter?
18 millimeter. Good.
Yeah.
Fine.
So.
So, Edwin, would you like to share your thoughts on the sizing and all for the beginners and all?
Yeah, basically, I most of the time end up using 18 only. Only reason why I use a bigger device is that their sizing is 18. I think it's 25 and 35. I think they have new size around 30 also this time, I think. So most of the PFOs are quite small, as we said, shown as.
So as you can see here, this is a 18 mm. So that means both the LA and RA disc are 18, and it's a dual disc design. Most of the PFO devices are of the same, almost similar design. So I kind of thread this device with the left hand.
18 size device, yeah, both devices are same size. When it goes to 25, the RA disc is 25 and LA disc is 18. Same way it goes to 35. The LA disc number is of the RA disc.
LA remains 18 in all. So we have to make sure that we load the device underwater. And I always take it out once, and once we screw it, just make sure, just get one point unlocked here so that you can deploy it easily. So underwater, you load it, and then just take out, remove the air bubble, and keep it ready here. And after that, we kind of flush it. So most of all air bubbles have gone, and now we have a air-free system here. Okay. Device, please.
So a question for the panelists. Anybody who does an ASD can do a PFO, true or false?
True.
Yes.
True. Anybody doesn't do a ASD also can do a PFO probably.
I think the important thing here is not doing this. Procedure is very simple, choosing the right case.
Right.
Exactly.
I'll do you, because the neurologists should be the gatekeepers of this therapy, because as you see, the procedure is nothing much. It's 5 minutes job.
You're right.
So, but I think you dwell on more on who deserves this therapy, and appropriate therapy is being delivered.
So I think that should come out from a heart-brain meet. Dr. Rihal, is that a norm, a heart-brain team?
Yes, indeed it is. And I strongly concur with that opinion that it has to be a multidisciplinary input, because PFO is so common in the population. Symptoms are so common, and it's very easy to ascribe causality when there is nothing. So we have all of our patients seen by a combined team of a non-interventional cardiologist, clinical cardiologist, and a neurologist who specializes in cerebrovascular disease. And if they agree that PFO closure is indicated, then they will send it to one of my colleagues who does that procedure. So I completely agree that's the way to do it, as you described.
Okay, as you can see here, what I did was just advanced the device to the tip of the catheter. Before I released, I just made sure it is still attached by pulling it back, and then advanced again, release the LA disc here. Now then we pull, and the disc assembly here, and once it starts getting touched here, can you go to the side, please? So after that, we see in a projection where two discs are separate.
Maybe for the beginners, it's better to have a TE when you do this procedure. Like
Yes.
somebody who has
I
expert
agree with it.
he doesn't need it, but then those who are
Yeah.
doing it for the first few cases.
I think it's actually a lot of imaging dependent procedure, but most of the time we
we tend to manage without
kind
it
of
most of the time.
actually this this view here itself says that the device is in the correct position, as Dr. Bernie Mayer described as a Pac-Man sign, where upper part of the cranial part of those two discs, LA and RA disc, gets separated in such a way that it simulates that old our video game Pac-Man. So that means your septum secundum is well caught inside the device. And another thing that I noticed, this is Treviso, the latest delivery cable. It is the distal tip is ultra flexible, and I can see that actually it's a device is already in the position, and it is you can see that bent, so it's very thin here. And I don't know, another thing we practice here is an injection in the RA. I don't know how many people do that, but I'm kind of a fan of it.
It's safer to do an injection. If you have transcatheter echo, you probably may not need it.
So, Dr. VG, imaging versus only fluoroscopic deployment. So, what is your take?
See, basically, we do imaging because to assess the shunt more than for imaging guidance. So it gives us an idea of how much, because these patients come for follow-up, then you end up seeing around 20 to 25%, even 25% have a residual shunt at around immediately 24 hours, but then 94% is functional closure. So I do it as a routine. Some cases we do ICE, but most cases because of the cost of the catheter, mostly we are TE based. So that's why we avoid the injection in the RA, and it gives us a perception of how big or how residual. I agree, fluoroscopy is more than enough. And like you said, the Pac-Man sign, the secundum septum is thick. So it bites into that, and the primer being thin, we have more apposition. And one more point is this: conventionally, unlike the AST device, when you orient it on its side and look, we don't generally do this because the PFO can be serpiginous. So you might not, it can be sort of fool you and give you uncomfortable moments.
So fluoro, whatever said and done, it is not foolproof. That's all.
So there's a question from the audience. Would you prefer to do under TE or in ICE? Do we need an ICE for this?
Of course, if it is ICE, it can be done under local anesthesia. Only thing is, it requires an additional large bore access in the vein, and of course, the cost does matter. So we don't have an ICE. So ICE would be definitely. I think now they saw some reports with 4D ICE also. So,
Dr. Rihal, what would be the practice there in terms of imaging?
It's generally ICE. Generally ICE, because ICE avoids general anesthesia, is much easier on the patient. With a transesophageal, typically we will intubate a patient, so it increases the complexity and cost of the procedure.
Basically, back here, the human services are cheaper, unlike in the West. So to get a TE done, I'm sorry to say it for bluntly, in the West, you need an anesthetist, you need an echocardiographer, a lot of things are needed. Back here, money is more, it's quite expensive to get ICE catheter.
Yeah.
So it is experience of ICE. I mean, we do have an ICE in our lab. I done a few, but then I stopped it because it's so easy, often very comfortable with a TE. And then in these cases, you need a TE only if at all to confirm the position. You can just do a TE and come off. You may not need a GA now. So, but for beginners, maybe a good idea to do a GTE or an ICE, but others I think can get away with a good transthoracic echo, so good enough.
So Dr. Edwin meant that humans are cheaper than the ICE catheter is what he
meant.
The sad truth,
Okay, so here
what does your angiogram show, Dr. Shafeeq?
Practically just shows that our RA disc, and in the levo phase we can just show the LA disc.
Yeah, that's very so it is the see the levo phase also.
Very good. So
Dr. Shafeeq, you have done it very good.
Very nice. So I think in that way we can save some imaging cost.
Yeah.
Exactly.
Of course, we have transthoracic, but Dr. Vijay, I take your point about residual shunts. This is not.
Yeah. So actually the importance of it is now there is a new paper which has come, which is published in Annals of Internal Medicine. I think it's from Harvard, where they looked at, earlier it was thought to be innocuous. But what they found is like when you classify it as small, moderate and large, the moderate and large got a significant risk of restroke, which is almost like the hazard is like 4 times. Compared to when you have a full closure, the hazard ratio is 0.75. So when you have moderate, according to their description, the TE guides anything more than 10 bubbles was considered a moderate and more than 30 was considered large. So it is not without consequence. So that is one. This is very recent data which has come about. But again, so small shunt, what to do? We generally don't do anything. But moderate to large, the question is, but I don't know of any how you can tackle it. Maybe that's where some prudence in sizing the device. Like Edwin said, if there is a large aneurysm, you choose a slightly larger device. Cribriform device is the multiple. All these come into play. So that's the importance of a residual shunt.
We have a practice of doing transesophageal at this end of 6 months when we are about to stop antiplatelet in younger individuals.
Yeah.
Do you do TE often?
No.
So so we do a agitated contrast saline study with if there is to see a shunt, I think 24 or 30. If there's a residual shunt documented, then we go about. So most of these sealed by around 1 year. Even in this study, the last study by Deng et al., I think it was done at 1 year when the anatomical seal actually occurs. So maybe it's prudent to assess like a residual shunt or not at 1 year and not earlier.
So you change your like anticoagulation or antiplatelet protocols according to this paper,
Yes.
or you are like
yes. If it's moderate to large, we do continue. Yes.
Dr. Anmol, what is your plan for follow-up? Usually, what protocol you follow? Do you consider doing transcranial again?
You mean a TCD?
Yeah.
That's
Anmol, please unmute.
Okay, I said, yes, we also follow the same way what Dr. Vijay has said. We usually don't do transcranial and other things.
It's actually extremely important to keep these procedures very safe because we cannot afford even a smallest complication in such patients because we are achieving in a very narrow margin here in terms of superiority over medical management. So procedure related complications actually has to be kept very least. So most of the time it is air embolism. Device related complications are very rare, but sheath and other induced injury to the LA is to be avoided actually to the maximum. So another thing is the choice of the device. So Dr. Edwin, how do you use any other? We have actually devices of same design in India.
Yeah.
So
most of them are same. So it's just a matter of like it doesn't actually change anything because basically we don't have other Gore-Tex or other devices are not available. So the routine devices available are all the designs are all same except the companies are. So I don't think it will really matters like which device you tend to use.
What would be the anticipated troubleshooting problems in a PFO, poor device seating? The long tunneled PFOs. There are reports where those are the cases which may not sit in very well. Any thoughts on those? Those tunneled PFOs?
I don't think deploying, I haven't had any trouble, any case. But the positioning is the only thing because unlike an ASD, the wiggle doesn't work here. The intervening attachment is quite stiff. So in a routine ASD, you may just wiggle in the LA view, make the separation of the two discs as a criteria to some extent, not if it is not foolproof, if at all it helps you. Here, the attachment between the two discs are quite stiff and small, like 5 millimeter stiff. So you pull, the whole device comes in. So never try a wiggle, sort of wiggle in a PFO device. And if at all in doubt, always make sure you have good imaging. Otherwise, it's a reasonably straightforward procedure.
So we have
Dr. Rihal, do you do any other device other than this double disc device in your cath lab?
Yeah, so I don't personally do a lot of these procedures, but my colleagues will occasionally use a Gore helix depending on the anatomy. But this is by far and away the most commonly used device in
Common
our
use.
Yeah, absolutely.
There is
And
a
as you've
stitch
demonstrated
device.
nicely, it's safe, it's relatively straightforward to use, and as somebody pointed out, the main goal actually is to avoid complications.
Exactly. We have a question
Yeah,
here.
yeah.
Is transcranial Doppler more sensitive when the contrast echo is negative? And would that mandate closure of the PFO? So is transcranial Doppler more sensitive
Good question, actually.
when the contrast echo is negative, and would it mandate closure of the PFO?
Actually, we have a series. Actually, all our cases, we are the publication in Press and Indian Heart Journal. We are around 88 cases, of which we have done 29 closures. So we had TCD done for most of them. Because it's again, because TCD, like Dr. Rihal said, is basically stroke neurologist domain. So it depends on the expert out there. What we found in our series, the sensitivity was around 78, but the specificity was 53% for TCD. So if it is a high clinical suspicion, I think you go ahead with do a good, agitated contrast cell, you do a good Valsalva, it is a must. So a TCD negative, I don't think should be the end of the story. The confirmatory test is a TE with a good Valsalva and a good agitated contrast saline study.
And probably, as we discussed earlier, probably try through the lower limb veins to increase your sensitivity for your contrast echocardiogram.
Femoral venous injection is higher sensitivity.
Exactly. And one more question. Does the atrial fibrillation incidence increase after PFO closure?
Yeah, actually, in one of the trial, there was a increased incidence device-related atrial fibrillation. How much is the long-term significance of it? It is still, we are not very clear about it.
It was early phase. It was, I think, the first 3 months. The first 3 months, it was a higher incidence, which respect trial or one of the trials. I agree.
Basically, it was not much with the Amblatzer device. It was more with the Gore device. And in the closed study, they had to use 7 different devices. So among the 3, I think the Amblatzer's data shows less incidence of wave. Unlike the Gore, which had around, I think, 4%, this had only some around 1.4% from the right.
There's one more question from the panel, from the audience. Should these patients with TIA and closed PFO, do they need lifetime aspirin?
Brilliant question, actually. Young people, after 6 months, if there is no residual shunt and if there is no further event, we can actually think about stopping aspirin. If there is any other compelling indication or any other risk factors, but then we can think about continuing. Dr. Vijay, what's your take on that?
Basically, this is where your rope score might help.
Yeah.
If the patient has got a very high rope score, you can stop aspirin. But if it comes in because the rope score is very dependent on the age. Now it falls in a category. You cannot generalize. It is an individualized decision. Now, if the rope score is low, which means an elderly patient has got diabetes, you would think of continuing. But like Shafeeq, I totally agree with you. High rope score, which is typically a patient 30, 40, no other risk factors, we stop at 6 months.
Great. And actually, it is interesting now because we have a lot of direct oral anticoagulants. How effective these will be, because whatever trial who came with WARF and all did not do very well vis-a-vis device. But how these NOACs can do in medical therapy.
Dr. Verma, your inputs on double antiplatelet versus single antiplatelet versus NOACs in this?
I think you're muted, Dr. Verma.
No.
Okay. Sorry. As Dr. Vijay said, if your rope score is very high and the patient is very young, I think single antiplatelet for a period of 6 months till the endothelialization is complete, and then you're safe to stop all antiplatelets. But again, as your age increases, as a number of other risk factors increase, then there is a bit of a gray zone. And then after that, there's a clear zone where you definitely will have to continue either 1 or 2 antiplatelets. So it's in the gray zone that you are not sure.
So great.
The in-between age where you do not you have some sort of vague risk factors, but not very sure. Rope score is somewhere intermediate, not very high, but at the same time not very low. A 45-year-old diabetic with well-controlled sugars.
Thank you very much, Dr. Verma. So I think, Dr. Shafeeq, I think we'll wrap up the live case session. It was a fantastic discussion from all the panelists and from you over there. A very well-seated PFO device sitting, staring at all of us there. I think you would like to close from your cath lab there, from all the team members over there. Yes, we can see everybody.
Thank you so much.
Nice case. Excellent case.
Thank you.
All right. So thank you very much.
Thank you, Dr. Vijay.
Welcome.
Dr. Vijay, Dr. Edwin,
Yeah, thank
Dr.
you.
Varma,
Thank you.
and Dr. Anmol.
Nicely done.
Right. Thank you very much. And with that, we will close off the live case session from Aster MIMS Calicut and Dr. Shafeeq's team. We will go on to our next session on valvular interventions. I request Dr. Rihal to stay over, and we go on to today's talks on structural interventions. I'd like to introduce our expert panelists for this evening today and this session. We have with us Dr. Manik Chopra, Senior Interventional Cardiologist from Narayana Hospital in Ahmedabad. We have Dr. Anmol Sonowani from Interventional Cardiologist and Structural Interventionist based in Mumbai. Thank you for continuing here. We have Dr. Rihal, Charanjit Rihal, sir, as from before. It's my pleasure to invite Dr. Nagendra Bhupati, my ex-colleague, Associate Professor and Valvular Heart Specialist from Sri Ramchandra Institute in Chennai, and Dr. Placid Sebastian, Senior Interventional Cardiologist from Aster MIMS, Kannur, from Kerala. A very warm welcome to all our expert panelists here today.
Thank you.
Right. First case. Percutaneous.
So I would like to invite the speaker, Dr. Charanjit Singh Rihal, for the first talk on percutaneous closure of paravalvular leak, tips and tricks. Dr. Charanjit Singh Rihal is the interventional cardiologist and chair of cardiovascular medicines from Mayo Clinic. He's a specialist in paravalvular leak closures, TAVR, transeptal mitral valve implantation, left atrial appendage occlusion, and mitral clip. Welcome to you, sir.
Well, thank you very much, and good evening to all of you there. I greatly appreciate the opportunity to spend some time with you this morning, and congratulations on a wonderful meeting. I am going to now try to share my screen, and let's see if everything works. Share screen. Can you see my screen now?
Yes, we can see.
Fine.
Yeah.
Okay, very good. So let me get started. So I've been asked to speak about a topic that I've been involved with for many years, as you know, and that's the very challenging problem of paravalvular leak closure. And just as a bit of background, we know that paravalvular leak or periprosthetic regurgitation occurs in 5 to 17% of valves. Severe is even less than that, maybe 1% or so. But the issue is it's often underestimated due to the difficulty of transthoracic imaging among these patients. There are many reasons for paravalvular regurgitation. You can read them for yourself. Annular calcification and tissue friability from prior endocarditis are two of the most commonly seen etiologies here in the United States. We know that perivalvular regurgitation can affect any type of prosthetic valve in any position in the heart, as you can see in this patient. We also know that there are different anatomies and different shapes and sizes of these leaks. The ones like in the upper panel that are more discrete are very favorable for percutaneous closure, whereas the larger dehiscences that continue around the sewing ring of the valve are less favorable for percutaneous closure. The advent of real-time three-dimensional echocardiography is what really revolutionized our practice in the development of procedures to treat paravalvular regurgitation. And I will be coming back to this image of a mitral bioprosthesis with a large paravalvular leak in the upper right-hand quadrant. So one important point I would like to make, and this is particularly important when people are first beginning to do this procedure, the so-called surgeon's view that our transesophageal imaging colleagues use is seen from the atrial side, from the upper side, so that you have the mitral valve here, aortic valve to the top right, appendage to the top left, and septum in the middle. On the other hand, the interventional cardiologist, who uses typically the left anterior oblique caudal view, sees a 180-degree opposite view with the mitral valve to the right, septum is here, aortic valve to the top left, appendage to the top right, and tricuspid valve to our left. So what the transesophageal imagers see and what we see in the cath lab is flipped. So if they say 3 o'clock or 9 o'clock, we have to realize they're in different time zones. And I don't like to use clock face terminology like 12 o'clock or 3 o'clock because we're not looking at the same image. So a very important thing is for our imagers to use anatomically precise terminology like anterolateral at the base of the left atrial appendage, posterior by the interatrial septum medially. So we use this anatomically correct and precise terminology to communicate. Now, the second most common question I get asked is, what about plugs? What sort of devices do we use? So in the United States, we do not have the AVP3. It's coming in a research trial. So we have typically used the AVP2 arterial vascular plug for almost all of our procedures. The issue with these devices, the septal occluder, the muscular device, or the ductal occluder, is that they're made of thick wire braid, and often high velocity jets will persist through these devices such that hemolysis can occur or even accelerate following percutaneous closure. So we do not recommend using the thick braid devices, and we recommend using the thin braid devices. Now, this is what we would all think would be a very nice ideal transseptal, and you've all done transseptal procedures. I know you do many, many in India. But with these patients, these are the type of septa that we are dealing with. They're thick, they're fibrotic, they're frequently patched, and sometimes even calcified. So you need to have a strategy to cross the septum using a variety of escalating techniques. And for those of you who are interested, we have recently published a review of this in JACC Cardiovascular Interventions. The one point I would like to make about the transseptal is that we must do a very posterior stick, really directed towards the spine, to allow enough room in the left atrium for us to turn around and work and access the paravalvular leak. So by far the most common question I get asked is, what about sizing? So as you can see in this image, there is a paravalvular leak here by this mitral bioprosthesis. Now, we no longer spend time measuring how wide this leak is. It's really not helpful. What we do is we measure the length of the leak and the distance from the middle of the sewing ring to the left atrial wall. So let's say that's 12 by 8 millimeters. We then will aim to treat that leak with two 10-millimeter devices covering up that entire rectangle. And so here's an example of a 69-year-old man who had a mitral valve repair in a ring, and he came back later with severe heart failure, and you can see right here there is literally a hole. It's a large paravalvular leak, and the way we treat this, I'm sorry for the video, is we cannulate this with a wire, send a delivery catheter through it, and then through that catheter we extrude our closure devices, in this case an AVP2, as I mentioned. Now you can see the distal retention disc and the proximal retention disc are nicely in position, and there's almost no residual leak. So this is an ideal circumstance when we have almost no residual leak. And here you can see that the device is nicely in position. It's away from the ring, away from the mitral leaflet. We have treated very, very complex patients. This is a patient who presented in pulmonary edema found to have multiple paravalvular leaks. We pulled in multiple devices, and look at this. The left atrial V wave fell from 60 millimeters down to less than 20. So this patient had an excellent result, and within a couple of days, her chest x-ray had cleared, and she left hospital within a few days. So that is our goal. Almost no residual leak and a reduction in the left atrial pressure. An important challenge, of course, is that we don't have oval devices yet in the United States. So we're trying to fit in these round devices. And round devices, if you use just one, you'll often have severe residual regurgitation and uncovered spaces if putting in a round device. This was early in our experience. We no longer would use this device, but it's a nice anatomic illustration. So as mentioned, we will typically use 2 or 3 smaller devices rather than one large device to cover up a paravalvular leak. And here's an example of the simultaneous deployment technique where we have 2 6-French guiding catheters in the left ventricle, and through them we're deploying 2 AVP2 devices simultaneously with them stacked one on top of another. And this technique is a very nice technique that allows us to get 2 devices safely into position, and we have to take extreme care not to interfere with the normal motion of the mechanical tilting disc, as you can see in this projection. Now, here's another technique to rapidly deploy and safely deploy multiple devices, and that's creation of an arteriovenous rail by snaring the wire and pulling it out the contralateral femoral artery. So what we've done here is we've created the rail. We're putting in the first device. We then take out the delivery system and advance it back over the rail, leaving the first device in position. And you can see we're putting the second device and then the third device. The beauty of this technique is right till the very end, we can reverse everything. If we're not happy with the result, or if we think that we're going to interfere with the mitral valve, we can remove everything. So it's a very safe, quick, and efficient technique for even the most complex mitral paravalvular leaks. What about aortics? Aortic we treat fairly similar. We go retrograde through the aorta, cannulate the leak. The biggest challenge, of course, is grading the aortic paravalvular leak because of what we call the garden hose effect. Even a small volume of high velocity jet can splash into the left ventricular outflow tract, creating a very large color flow Doppler signal, looking like severe AR when it isn't. So we use hemodynamics as illustrated here, and as well as angiography sometimes. So this is an example of how we're putting in the distal retention disc into this aortic paravalvular leak. And there's the proximal retention disc. The device is now nicely sealed in position, not interfering with the tilting disc of the aortic valve. One of the really important things that we realized with the aortic PVL is that CT is indispensable. The CT allows us to localize not just the anatomy, but the position of the aortic PVL very clearly, such that we can set up our gantries, find it, and very quickly cannulate and treat. This is an example, I won't talk too much about this, of how we treat post-TAVR PVL. The only thing I will say is that this has become an incredibly rare procedure, particularly in the centers that are using devices that have skirts or seals around the TAVR device. I can't remember the last time I did a post-TAVR PVL closure procedure. Now, we and others have published our results, and the most important lessons I've already mentioned actually is that the optimal long-term outcomes are found amongst those patients in whom there's less than mild, trivial or mild residual paravalvular leak. If we leave moderate paravalvular leak, that patient undoubtedly will be coming back for surgery or a redo procedure. We also know that the patients in whom we can reduce the left atrial pressure do well, and actually can do very well for a number of years in comparison to those who have maybe a stiff left atrium or moderate residual leak, and the LA pressure does not drop. So most important lesson is our goal should be to have trivial residual paravalvular leak using 1, 2, 3, or more devices. What we tell our patients is that now, given the techniques that we have developed, that the chance of them having an uncomplicated, successful procedure is at least 90%. The incidence of complications ranges from 2 to 5%. Many of those are bleeding complications. And so we alert patients about that and are very careful with transition of anticoagulation. So to conclude, paravalvular leak is more common than we think because it's typically underdiagnosed. We know that endovascular or percutaneous closure is feasible. There's a significant learning curve. As I'll mention now for the third time, residual regurgitation is the key determinant of outcomes. And we know that PVL closure improves symptoms, improves hemolysis, lowers the need for subsequent surgery, and is associated with lower mortality in the long run. There's many series that have demonstrated this now in the medical literature. So I hope this was of interest to you. We've left a few minutes for discussion, and I would be happy to hear your thoughts and to learn about your experience. Thank you.
Thank you very much, Dr. Rihal. Fantastic talk. Great insights and the tips and tricks into paravalvular leak closure. I think will be a great benefit to all our viewers sitting here today. I think we'll kick off our discussion today. Dr. Bhupati, could you give us some insights regarding your practice in such a thing? What are the difficulties one would probably face in such a situation here in a paravalvular leak closure? Any insights? You're mute, Dr. Bhupati. I'm not sure we can.
Yeah, am I audible now?
Yeah, yes, you are, Doctor.
Yeah. Thank you, Dr. Salman, and the Astromims team for providing this opportunity. It was indeed a pleasure to listen to Dr. Rihal, who is one of the best operators in the world for paravalvular leak closure. I don't have anything else to say. Whenever I listen to him, he makes the talk he makes the procedure so easy. But let me tell you, it's the most complex structural intervention that one can perform. I would say it's equivalent to a CTO with a JCTO of 3 or 4. So, Dr. Rihal, in your experience during the initial part when you started doing paravalvular leak closure, how did you select your patients?
Yeah, first of all, thank you for your very kind comments and excellent question. You know, when we first started doing this in the late 2000s, there was no guidance, there was no, experience. So we literally had to learn and develop and innovate as we went along. And so the way we did it, I teamed with my pediatric congenital structural colleagues. And the reason is they were experts with all the different devices. And I was not, but I was good at left atrial procedures and working with elderly patients. And what we quickly realized is that the patients with smaller, discrete defects are the best ones to do when you're first starting. We then realized that the antegrade transseptal approach, once you learn to do it, can actually make it much easier. And the trick is to use a deflectable left atrial sheath. When you start using the deflectable left atrial sheath, it allows you to select a wider and wider variety of patients. And so it was a combination of procedural innovation, a combination of finding better equipment and then adapting that equipment to this procedure. Now, what we can do is if an experienced operator visits our lab and we show them 2 or 3 cases, then they go home and maybe we proctor them in 1 or 2 cases. The learning curve is very quick for experienced transseptal operators. So somebody who's done balloon mitral valvuloplasty, like in India, you do so many of those, or doing mitral clips. Operators who can do those procedures can learn paravalvular leak, I think, quite quickly once you get the right training.
Dr. Manik, any comments?
Yeah, good evening, Dr. Grahal, and it was really a pleasure listening to you. My only question is, in India, there are many centers at which we are basically lacking 3D TEE, and most of the information is either probably, we of course can get CT scans done for planning our gantry, which we typically do. But regarding the 3D part, I mean, for aortic, of course, it's easy. to go without 3D, but for mitral, I mean, sometimes it is really tricky, and our experience with the echocardiographer showing us the right view and all those things are really a problem. So, is there any, I mean, trick, to manage that? Because once or twice I almost placed 2, 3 devices and still the leak was not closing. The echocardiographer was without any inputs, and we were really stuck.
Yeah, this is a great question, and the way we have managed this is we have selected a small number of echocardiographers who are very interested in structural interventions. Like our general echocardiographers don't come and do these procedures with us. We have 4 or 5 who are highly interested in interventional cardiology and OR imaging, so they're the ones to do it. So my recommendation would be to identify a colleague who's as interested in operating room and cath lab imaging as you are, and then work with that colleague to develop a true partnership. And then you learn together as you go. But you can't have just a general echocardiographer coming in. It's too complicated.
Yeah, I agree.
Dr. Rihal, one question from me would be, you showed two devices simultaneously deployed in one of the cases. Do you really think that presence of those oval devices like Occlutech or the 3 device would, can replace as a one device in such
great
lesions?
question. Yeah, I think for many patients, one oval device will do the trick. However, my colleagues in Europe who use that device tell me that it's not a panacea, and you still often need to put 2 devices in.
Oh.
But the answer is yes. I believe the oval devices will help and make the procedure even more simplified. But it is a complex procedure and will remain a complex procedure.
Totally agree. I agree with Dr. Bhupati's statement as well, that it is not as simple as it is seen in your presentation. And as I think that railroad technique is the one which is, where we can take it out or come with a device again, or come with multiple devices simultaneously. I think that is the key to maintain that pressure. Your co-operator can stabilize the system, and we can advance the devices. Yeah, thank you.
Yeah. One more question, Dr. Rihal. I mean, of course, we are all beginners in this PVL field, but we know that probably we'll have to select short, small crescentic defects for the mitral ones. But what would be the largest one? I mean, what is your threshold for the, in which you say this is no for PVL? Is it 30% of the circumference? Is it the device being unstable? What is your threshold? And what would be the right level?
I think it depends on the operator experience. When you're first starting, I would not tackle a PVL that takes more than 2 devices. But once you have developed a comfort, then yes, you can do 3, 4, 5 devices up to about 30% of the ring. There's really technically no upper limit. It all depends on the risks and benefits of what the risk of redo surgery is. So but I would say as you're going up the learning curve, don't try to do leaks that take more than 2 or 3 devices.
Dr.
Placid, I have one question for you. Is there any other specific technique you use to enter the PVL that is located in the IAS side of the mitral valve?
Yeah. So
it's very difficult to enter into the IAS side.
Yeah. Thank you for your question. What I use is a small curved Agilis sheath. So the Agilis sheath is used by the electrophysiologist for left atrial ablation. And I don't know if you can see my finger, but it allows you to really flex, make a nice tight flex. And so you have to do your transeptal posterior towards the spine, and then put a small curve Agilis and flex it towards the septum. Then you'll be able to enter it with a wire.
Unfortunately, in India, most of the vendors have this medium-sized ones. I mean, we tried. I mean, one of them was ventromedial, but I think the CT gantry helped us in both NFAS and alveocaudal view. We were able to somehow cross.
Have you ever encountered that you are not able to put a specific device and a particular patient needs a 3D print specific for the particular patient, a kind of 3D printed device for an individual patient?
That's a good question. The honest answer is no. Once you learn to understand the anatomy with with CT and with transesophageal, you have to remember that 3D printing is just a CT scan, right? All you're doing is taking the data from the CT scan and printing it. So the best way to do it is to learn the anatomy in your mind and do it in your mind. And then when you have the anatomy absolutely clear in your mind so you know where it is, then you can go into your procedure and find the leak quickly. So I think maybe initially when an operator is learning, yes, you can print it out and you'll give you an understanding of the anatomy, but ultimately you have to do the 3D printing in your mind so you understand exactly where the leak is, if you know what I mean.
Dr. Placid.
Thank you, Dr.
Dr. Vihal, I have a question. Do you use ice when you do septal puncture? Is it mandatory?
No, the answer is no. We typically will do the septal puncture with transesophageal. You know, we talked about the TEE earlier. And I'll tell you one advantage of the transesophageal is you have a second cardiologist who's doing the imaging for you. So if you have a specialized imager, then you and that imager can talk and you have two minds thinking about it. The problem with ICE, I've seen this many times, is the operator gets distracted by doing the imaging and then takes his or her focus off the procedure, and that can cause complications. So I think if you're doing your own ICE, you have to be very careful as you're doing these very, very complex procedures.
I think that was fantastic. For want of time, we'll go on to the next session. It was a fantastic discussion on paravalvular leak closure. Dr. Sai Satish has logged in, and that he would be going on for the next topic, mitral clip basics and beyond. I'd like Dr. Anil to introduce Dr. Sai Satish.
Thank you, Dr. Rihal. Really appreciate your time.
Dr. Sai Satish doesn't need any introduction. He's an internationally renowned senior interventional cardiologist from Apollo Hospital, India. He's also a practicing interventional cardiologist and teaching faculty at one of the world's best TAVI training centers, the Gottskeen Institute of Cardiology in Budapest, Hungary. He's a pioneer in the field of transcatheter valve therapies. He holds a reputation of having performed the highest number of percutaneous edge-to-edge mitral repairs in the subcontinent. Over to you, sir.
Hey, thank you so much. You know what? After Dr. Rihal's lecture, I am I just want to make it very simple by saying Albert Einstein said that if you can't explain what you're doing to a 6-year-old, then you probably don't understand it. And the beauty with which he broke down the complex procedures was just a work of art. It was a pleasure to listen to you, Dr. Rihal. And with that, I'm going to move on to my talk. Here we go. There's some, can you guys see my screen? Can you see my screen?
Yeah, very much, sir.
Oh, perfect. First of all, thank you so much, Shafeeq, for having me here. And like I said, listening to Dr. Rihal was mesmerizing. My topic for today is I'm going to occupy you for about 15 minutes on mitral clip. Very quickly, I'm going to go through heart failure. There are about 26 million cases of heart failure patients worldwide. About 37.7 million if you take the undiagnosed cases as well. I don't know how many of you know, but we have 1 in 5 lifetime risk of developing heart failure. It's the #1 cause of hospitalization today. And over 50% of these patients are re-hospitalized within 6 months. Now, like all roads lead to Rome, several reasons why this happens. Increasing life expectancy, diabetes, hypertension, obesity. We have about 4.5 million heart failure patients in India alone. These patients have a very poor quality of life with a 60% mortality in 5 years, and mitral regurgitation is a significant component of these heart failure patients worsening their outcome. When we talk about mitral regurgitation, there are 2 broad classifications. You have the degenerative mitral regurgitation. Just 1 second, I'm going to turn on my timer. There we go. So you have degenerative mitral regurgitation and you have functional mitral regurgitation. The degenerative is what involves the leaflet, the subvalvular apparatus, the Barlow's, the flails, the caudal ruptures. And then you have the functional, where you have the cardiomyopathies, where you have ischemic cardiomyopathy, where the LV dilates, moves the mitral leaflets apart, thereby causing a non-coaptation and the mitral regurgitation. Mitral valve disease is about 2 to 3 times that of aortic valve disease. In America, about 4 million cases of mitral regurgitation are diagnosed every year. Only 1.5% are treated. Now, what is the MitraClip? The MitraClip is a reconstruction of an insufficient mitral valve through tissue approximation. It's a recapitulation and refinement of the Alfieri stitch, a mechanical solution to a mechanical problem. These are just some of the studies that involve and revolve around the MitraClip. I'm not going to go into its details, but while COAPT has been done and dusted, and I'm sure all of you have heard several presentations, I want to just cover a few points before I move forward. In patients with heart failure and secondary MR who remain symptomatic, MitraClip was safe. There was durable reduction in MR, reduced the rate of heart failure hospitalizations, improved quality of life and functional capacity, and improved survival over a 24-month follow-up. As such, the MitraClip is the first therapy shown to improve the prognosis of patients with heart failure by reducing secondary MR due to LV dysfunction. A quick note on EXPAND. EXPAND pretty much took all the FMR patients that enrolled patients that belong to the FMR category that fit the FMR criteria in the COAPT, and also threw in the DMR patients. And it was no surprise that the results mimicked the FMR group, even in the DMR group, with significant reduction in heart failure-related hospitalization, improvement in quality of life, and mortality. With that, I'd like to go on to a few cases. The first patient I have to discuss today is a DMR with cardiogenic shock. 86-year-old gentleman, diabetic and hypertensive, acute circ tertiary infarct, flail caudate papillary muscle rupture, severe acute MR, cardiogenic shock, lactate climbing, creatinine 1.9. I get a message from the family saying that we are not able to get him off the ventilator. We are not able to get him off balloon pump. We are shifting him by air ambulance. Can you help? So you can see from this image, the flail P2 overriding the A2 with a torrential eccentric jet of MR. Now, cardiogenic shocks are never fun to do, even for MitraClip operators, because unlike the FMRs, the LAs haven't had time to enlarge. So this LA was really small. It was about 2 centimeters by 3.5 centimeters. Hey, can you guys hear me? Hello?
Yes, we can.
You are very well audible.
Very audible.
Okay, perfect. So a small LA, and if I perform the septal puncture traditionally mid-septum, mid-fossa, like I would have, I would never have had enough height to go after this MR. So you can see this really high unconventional puncture. This was just below the SVC-RA junction. And the LA was so small that those of you who are familiar with MitraClip will realize that I have to perform something called a straddle, where I get these 2 points of the clip to go on either side of the guide catheter's marker. But even before I could get to that, I'm already in the superior pulmonary vein. So at this point of time, I don't think moving posterior or any other knobs would have helped me. The only thing I had to do was I had to pull my entire device back, fully cognizant of the fact that I'm going to have my guide catheter in the RA while doing this clip. And you can see how the clip just fell in here. You can see how it just falls in free from the pulmonary vein into the LA. Once it's in the LA, it's clear of the Cumedian ridge. Did the right amount of medium to get it where it is. Went to 3D enforce, made sure I was perpendicular. And here you can see nicely the leaflets bouncing off in the LVOT view. You can see the leaflets nicely bouncing off the open clip arm, and you can see the movement is less once the grippers are down. I quite like to turn on my color at this point and see if I've got the MR exactly where I want it. That's with the clip closed. And I'm just throwing in some fluoro images so it will help you associate with what's happening in the echo. The more and more clips I do, the less and less I'm using fluoro. And you can see the torrential MR went to almost nothing. This is the double orifice. The gradient was extremely low. And you can see 40 V wave, 21 mean came down to 13 and 12, I think, on table, or 10 on table. And after 11 days and swapping the balloon pump to 2 groins, this is a patient 12 hours after the procedure. And that is him exactly 1 week after the procedure playing with his great-great-grandchild. The next patient I have for you is an FMR with cardiogenic shock. And as you can see here, 72-year-old male, diabetic, hypothyroid, old MI in 2005, severe biventricular dysfunction, EF 25%, severe MR, worsening on max medication, liver enzymes in the thousands, creatinine 2.4, typically low output state, metabolic acidosis, lactate climbing. They were trying to fly him in by air ambulance. The first air ambulance refused to pick him up because he was too sick, barely holding pressures by the time he reached me. You can see this abysmal LV function, torrential MR jets, huge non-coaptation gap of almost 1 centimeter. My anesthetist was quite unhappy about me doing this case, saying that the LV is so bad that I'm not sure that it'll deal with the afload after you clip it. So you can see the LV hardly moving. And this is the first clip. So my initial plan was to put one clip in and actually leave a little MR back, see how the LV behaves.
Salman,
hey guys,
please keep others mute, please.
Yeah, there's a lot of, I can hear a lot of voices. Okay, perfect. Thank you so much. So as you can see, we got a nice perpendicularity. I moved the clip as medial as possible because my initial thing was to just put one clip and get out. And when I released the first clip, something interesting happened. My anesthetist was purging supports to keep the blood pressure up. And suddenly he said, what did you do? All of a sudden, my pressures are better. My CVP is down from 36 to 28. And that gave me a little confidence to actually take the second clip in. And this is something I like to do. I line it up nice and close to the first clip, and then I just go lung down, and it hugs the first clip nicely by gliding medially. You can see one clip in the LV, the other one in the LA on the residual jet. And then the huge non-coaptation gap gone with a nice coaptation line with two clips in place. The severe MR is down to trivial. 84 V wave down to 26. Mean pressures followed. On table, you can see the improvement. By the time the procedure is over, the lactate of 9.57 when he came in is down to 1.36. CVP from 36 is down to 6. This is how his monitor looked post-procedure. Over the next 3 days, his creatinine became normal. His liver enzymes started normalizing. This was him 12 hours post-procedure, and this was him 36 hours. So this therapy works, and the results are super promising. I see I've done about 7.5 minutes. So I might show you just one more case. I'm not going to go into this patient. Is another FMR who took one clip. I did this patient in 2019, and this patient is important to show another huge non-coaptation gap. And this patient is important to show because every year from the day I've clipped him till now, he sends me a message every month saying, "Good morning, sir. Thank you for this miracle. Dad has improved so much." This is him 3 years later when he came for his follow-up. He hasn't had one heart failure-related hospitalization in the last 3 years. I'm just going to skip this patient, and I'm going to go into this patient. I'll take another 3-4 minutes for this patient, and then we'll open the floor for questions. This was a patient I did about a month ago, a 41-year-old farmer with no comorbidities. He was healthy until early this year. For those of you who saw TCT, I actually did this case as a live case. This patient came in just before my scheduled live case, almost crashing. He had one episode of heart failure early in Jan, 15% heart function, severe mitral regurgitation, refractory heart failure, was put on a transplant list, worsening on medication, no availability of heart, and just barely managed to get into a hospital. Look at that LV. This LV is about 8.5 centimeters. Did an MRI. The MRI showed no scarring. The muscle was looking good. So I was actually hopeful that if at least I thought I would be able to give him a bridge before he could get a heart. When you look at this image, I want you to just focus on two things. One, you can see how the mitral annulus is stented downward, which shows that this is a functional component as well because it's a hugely dilated LV. But also you can see a nice flail of the P2 segment. So this was both an FMR and a DMR. And in the 3D images, you can beautifully see the flail segment and the torrential wide MR jet. So went in, put one clip, abolished the first jet. There was still an eccentric jet from the side of the clip, took a second clip, put two clips in. The MR went from severe to trivial, as you can see from this tiny jet. So you can see the clips in place. You can see hardly any leak. You can see the nice double orifice here. The LAV shot down from 70 all the way down to 31. This was the patient just 12 hours post-procedure. He went home walking 6 days later. And the interesting thing is I saw him just 2 days back in my outpatient, and he had his LV size from 8.56 to 7.2. His heart function was at 35%. His RV function was now normal, and he was doing extremely well. I'm so hopeful that he might even get off the transplant list. Thank you all for the patient hearing, and that's it. I hope I was not too fast.
No, that is fantastic, Dr. Sai Satish. In fact, fast is an understatement for those fantastic bailout cases which you just presented. Wonderful case presentations there. I think I'd open the floor for discussion. Dr. Shafeeq, our course director for today, what are your insights on
Sai Satish, excellent talk, exotic cases, I should say. In an academic point of view, I would like to ask your tips for transeptal puncture, that is one, and two, which type of valve that you see on echo, or which type of regurgitation that you will not take this patient for mitral clip. I mean, how do you exclude?
Okay, so first I'm going to go for transeptal. Now, it's easy for me to explain this because I got really familiar with the procedure over the last 3 years. So the memory is fresh in my head. We are so used to doing transeptal punctures when we did BMVs while we were in fellowships by having a biplane and putting a pig in the aorta and making sure that we were away from the aorta. But over the last 3 years, I've not had to look at fluoro for my transeptals. You need just two views. You need your bicable view where you go all the way up into the SVC, drag your catheter down until you start tenting mid-fossa. Once you're tenting mid-fossa, you have 2 finger breadths between your needle and the sheath, and you keep going clockwise, which means you turn posterior. And all you have to do is either get a short axis or get your echocardiographer to explain your tenting in the bicable, and you just want to make sure that you are far away from the aorta and posterior. So you want a superior and posterior puncture.
Excellent.
Now, traditionally, when you're superior and posterior, you look at the distance from that point, you draw a horizontal line, and you draw another horizontal line at the mitral annular plane. And if you're about 3.5, 3.6, your life is easy. Now, the single most important thing you've got to spend time on in mitral clip is your puncture. Because your puncture is wrong, you won't be able to get your clip coaxial to the valve, and you will take a 30, 40-minute clip, and you will struggle for 4 hours. So I've learned by bitter experience that if I have to redo the transeptal, I will redo it, but I will get that transeptal where I want before I do anything else. Over the last 6 months, I have been pushing the boundaries and taking cases that I probably shouldn't be taking. A few weeks back, I did a 41-year-old surgical gastroenterologist with a mitral arcade where the papillary muscle attached directly to the mitral valve tip. And it was extremely crowded submitral apparatus. It was a nightmare, but we managed to get away. So there are several definite contraindications of the type of valves I won't touch. One, valves without enough valve area would be a big issue where there's rheumatic involvement and there is already a narrowed valve area. That's a definite no-no. Small calcifications at tips of leaflets I will take, but big calcifications, I don't think I'll be able to grasp them. If there's not enough leaflet length and if the leaflets are all bent over and pulled back, then it might be difficult to get very large coaptation gaps. But now there's so much of inventory in the MitraClip armamentarium. We have these XTRs with wider arms where we can go after these really myxomatous leaflets. We can go after these white gaps. So I think we are pushing the boundaries and feeling our way around. But that's it. Sorry, Shafeeq.
Great comments. Yeah.
Dr. Bhupati, you want to share some comments on this?
Extremely well done, well performed, well executed cases, Dr. Sai. No more words to add. In general, if you look at the anatomy of the development of a intra-atrial septum, the thinnest portion of the intra-atrial septum is the real intra-atrial septum. Given an opportunity, given a chance that what Dr. Sai did, that he went and performed the septal puncture in the thicker portion of the septum, I would hesitate 1,000 times because wherever I step, whenever we encounter pericardial effusion, is the site where we puncture the thicker portion. That is called as the Sandergaard's or Watterson's groove.
Absolutely.
We can use the advanced knobology A and P to gain or lose height But that was a case where the atrium was so small, so Dr. Sai didn't have any other opportunity, any other chance rather than to take a chance. Even if the patient develops tamponade, let me put a pigtail and then clip him and then continue with the procedure. That's the last thing that we can do, but that's the rescue. There's no other option in the particular individual with the LA size of 2.3 and 3.6. Nothing could have been done rather than to take the chance and proceed further. The second one, Dr. Sai, I have a question for you. How do you encounter the patients who are having primary MR with secondary MR and primary acute MR and primary chronic MR? Do you categorize? Do you approach them differently, or do you all are the same category of patients?
Very, very simple, right, Bhupati? First of all, to your comment about the septal puncture, that's sage advice. My heart was in my throat. I can't remember the last time I could feel my chest pounding while taking that puncture, but I had absolutely no choice. And the second thing is I was blessed with an extremely good echocardiographer. I have Professor Chandrasekhar with me from Mayo Clinic, who would tell me, and I would tell him, sir, I will be going out of the heart and coming back into the heart. There will be pericardial effusion, and he'll say, take the stick. And I have been blessed with that kind of backup. So I took the stick, and it was a compassionate stick. 86-year-old man, almost crashing. I had no other choice but to do him. And like he said, I was ready with my pigtail. Worst case scenario, no antiplatelets. Do it, reverse the heparin, don't give antiplatelets, put a pig in, and deal with the PE. But coming back to my acute and chronic MRs, Bhupati, we are in a stage with the COVID and with MitraClip in India where beggars can't be choosers. Okay, I get all kinds of cases, and the only criteria I have to choose the cases that will MitraClip help him. If I feel that MitraClip will help him, I have some restrictions because MitraClip is still under PMS, and Abbott is very strict about the kind of cases we take. They're not very fond of doing acute MRs, acute primary MRs, the cardiogenic shocks, but these are the cases that also show the greatest benefit because there's pretty much no other option for them. So as long as I have a clippable patient, like again to mention, I didn't have time to upload the case, but the case I did, the doctor who I did, was very interesting. Restrictive cardiomyopathy, giant LA, giant RA, LA kind of MR, annulus stretched apart. Patient was referred to me by Dr. Saibulkar. And when we went in, did one clip, small annulus, 41 years, 39 kilos. I said, my God, I'm done. Let me get out. And I thought, should I put another clip to stabilize? Because there was so much of LA stretch, I thought this clip might come off. But the minute I finished everything, I said, it looks good. I don't want to touch it. While I was coming out, torrential right to left shunt, desaturation because RA pressure was so high. Closed with a 12 millimeter ASD occluder, got out. Next day morning, I find her sick again, and I find that the clip has SLD, come off the AML. So I take her back, lasso the knob, take a 65 centimeter, a 20 French sheath, counterpose it against the septum so I don't rent the septum while I pull the occluder out into it, extrude it, go back through the same hole, put one clip to the left, one clip to the right to stabilize it, and take the same occluder, close the hole back and come. So, I mean, it was a nightmare, but like I said, these are the kind of cases we're getting now. I think I've taken so much time, I feel almost guilty.
Great indeed.
We are so passionate to listen to you, Dr. Sai. Extremely well done cases.
Great. Any comments from our other panelists?
One of your cases, you had a LV internal dimension of 85. I'm pretty sure that it's a kind of out of the box cases because clearly the FDA recommendation says LV internal dimension more than 70 is a kind of absolute no-no for MR. And if you look at the natural history of patients who have got a clip in co-op, the mortality rate at the end of 2 years is 30%, whether you do clipping or not. Once you go for these kind of therapies, I would say even in the United States, they give the hope that the chances for him to live after a couple of years is going to be 60-70% in spite of having GDMT and MitraClip therapy. So some patients may prolong after a couple of years, 3-4 years, and because even after clipping, the prognosis is not great. The disease is a killer. So I would say we have to, even the therapy is evolving. We may have to select the appropriate kind of patients to do a clipping in a patient who has got LV internal dimension of 85. My God, that's why that is amazing.
No, but you know what? It was the fact that I had the MRI. There was no scarring. He was only 41 years old. Acute onset of disease, post-COVID, transplant list. I had hope because of the MRI that he might make it. And I hope I'm right, Bhupati, but I know. I feel you. Everything you said is absolutely right.
Dr. Sai, how these
State cases,
patients are
Dr. Sai.
doing on a follow-up in terms of gradients, especially those who had two clips and the guy with that tough submitral tissue?
The lady,
Yeah.
the doctor. So
Yeah.
I was scared to put a second clip because of the gradient, and I ended up having to put 3 clips next to each other. Okay, and the gradient was 5. So the beauty is that if you stack these up so close to each other, sometimes you get lucky, and I think sometimes you have to be blessed. I always say this, you know, I sometimes say that I have more faith in my prayer than my skill, and people get really freaked out by it because I say my skill has limitations, my prayer has none. So sometimes I just think
That's being very humble there. Interesting. Great. I think we're going to wrap. Any last comments by Dr. Placid? You want to add something before we close this session?
And Dr. Sai, excellent case. I think you have pulled many cases out of the grade. And I know it's very interesting to see those cases. I hope you have done some simple cases also.
Yes, I have.
Okay.
Great. So I think that was a fantastic talk there, Dr. Sai. A fantastic discussion by all our expert panelists. A very warm thank you to Dr. Sai and Dr. Rihal at this session. A very warm thank you to all our expert panelists, Dr. Manik Chopra, Dr. Bhupati, Dr. Anmol Sonawani, and Dr. Placid Sebastian. Thank you very much. Thank you very much indeed.
Thank you, everyone. Thank you.
Bye, everyone. Enjoy your weekend.
Thank you. Thank you. With that, we'll go on to our next session on stroke prevention, an interesting turn of events over here. We'll go on straight away. I'll invite our expert panel here. It is my honor indeed to introduce Professor Lars Sondergaard from Denmark onto our panel here. A warm welcome to you, sir. We also have with us Professor Rajesh T, clinical professor in Amrita Hospital, Cochin, Kerala. We also have with us Dr. Arun Gopi, director and head of electrophysiology and heart failure from Metromed International Cardiac Center, Calicut, Kerala. And we also have with us Dr. Praveen Srikumar, senior cardiologist from Aster City, Cochin. We also have with us from our sister specialty, because this session is on stroke prevention, we have with us senior intervention neurologist, Dr. Paul Alapat from Aster MIMS, Calicut, Kerala. A warm welcome to all our panelists, and we'll go on straight away to our first talk of this session. Dr. Anil Salim.
The talk is about LA appendage device closure. It's by none other than the authority, Dr. Ranjan Shetty. He's the professor and head of the Department of Cardiology, Manipal Heart Foundation, Bangalore. He has one of the most extensive experience in the topic. Over to you, sir.
Yeah, thank you, the organizers, and thank you, Chairperson. So I will, it's very difficult to follow Dr. Sai Satish presentation because it's always so good. So any speaker who follows him will have a tough time following. So I'm going to talk about left atrial appendage closure, the tips and tricks as needed. So we know that AF is very common, and AF is it's responsible for around 1/3 of the stroke. The stroke produced by AF is more disabling, and it's more problematic. There is no mortality, there is more morbidity, and AF is very common beyond 60 years of age, and beyond 80, up to 10% of the population could have AF. There is a good treatment, that is oral anticoagulation, and anybody with a higher CHADVAS should receive it. There are also drugs, what we call as direct oral anticoagulant, but majority people do not receive it for lots of reasons, because the very patient who is likely to benefit with these anticoagulation is also the patient who is likely to bleed, because their BP is uncontrolled, there is history of fall. So still a large percentage of people do not receive these drugs, and they do not receive in the therapeutic dose. They are always on the lesser dose, and they're not very compliant. So there has been a need for alternative therapy in in some of these patients, and that is left atrial appendage closure. The rationale for alternative therapy has been that studies showed that the site of clot in non-valvular AF is actually left atrial appendage. In more than 90 to 95% of the patients, it's in left atrial appendage. So if you can safely close it or exclude it in circulation, it becomes a good option. And there are trials like Protect and Prevail, which did show this aspect. But having said that, its therapy is still underutilized. We need to define non-valvular AF here. Non-valvular AF, valvular AF actually means AF with moderate or severe mitral stenosis or a prosthetic valve. Any other AF is actually non-valvular. That means if you have MRAF or aortic valve with AF or even HOCM with AF, it will still be called non-valvular AF. Now we do know that appendage have been classified into different morphology like chicken wing cactus, but then it's unique. Each person's appendage is as unique as your fingerprint. So although we like to classify with different names and different structure, but still when you actually go in, the anatomy is different. But fortunately in today's era, whichever device you have in your shelf, 98.5% of the LA can be closed. That means you don't need more than one device in your shelf, and also you don't need lots of pre-imaging. In our center now, we only image on table. We don't image before. There are centers where CT is done and other imaging is done, but most of these may not be needed. Most of the time when we go to proctor, I request them to do one TE to rule of the left atrial appendage clot more than anything else. The anatomy usually works okay, and the LA itself is hydration dependent, and hence the size and the calculation vary a lot. Now in LA, what is recommended is, right, there are 4 devices which are available now. We have Amulet, we have ACP, we have Lambre, and we have Watchman. I think what is important is initially get comfortable with one set of devices, understand the device well, and as you understand the device, as you understand the procedure, then shift to a different device. Thereby the learning curve is becomes better, and the procedural success increases markedly. Now, LA has 2 axes. One is the axis of the neck, and second is the axis of the body. So your measurement depends on the device you want to use. So if you're using a Watchman for a same LAA, the numbers would be different. If you're using ACP, Amulet, or Lambre, your number would be different. So here, and it's also important to measure it in multiple views. You need to do it at 0, 45, 90, and 135, and based on that have some measurement. So I want to discuss Amulet today. Hence, it's a device which would actually sit on the neck of the appendage. So the measurement here will be at level of circumflex, and you may make a perpendicular line and have measurements in different sizes, different views. Once you have a measurement, the device upsize is by 2 to 3 millimeter. We don't expect the upsize to be too much, because too much would, the device would actually be pushed out. So adequate upsize is what you need when you are implanting left atrial appendage. So this is the T image. T is probably one of the most important imaging which we need during LA. And right now, most of the time, T is in our center is done with the conscious sedation using Dexmat, so patient is not intubated, and circumflex becomes a very important landmark. A perpendicular line here is the measurement which is important, and upsize by 2 to 3 millimeter. Upper pulmonary vein is shown. So the device Amulet is now available for around 2 years in this country. It fits into the neck, and it has 2 parts. One is the the lobule, and other is the disc. Lobule is the one which will hold itself at the neck, and the disc would cover the appendage beautifully. So there is double protection when you use devices of this kind. There are hooks. Almost all LA devices have hook which would anchor itself into the left atrial appendage. Devices without hook actually been withdrawn because embolization is very high, and as we discussed, it has to be in the neck. There is waist, and there is a disc which would actually cover the atrial appendage. This is also a nice when the device you can make a small gola. If you once you look at LA, you realize it's a very paper thin structure. So as much as possible, your the manipulation inside LA should be avoided. So this is how it looks. This just remember this picture as we go through. You realize using this gola to bring the device down. After around 45 days, the device gets endothelized and LA most of the time perfectly gets excluded from circulation. Now, this device comes between the sizes could vary from 16 to 34. Since the up size is 3 to 4 millimeter, you will be able to close appendages whose neck diameter is from 12 to say 31, 32. Bigger than that is difficult. At final deployment, this is how the device looks. The ideal position is actually this, where the device is slightly compressed and the disc is concave in shape, not any funny shape. There's good separation between disc and the device, and it's tire shaped, it's slightly compressed. If you have an undersized device, it would look like this, where the separation is loose and there is no device, there's no compression at all. This is not preferred because one, there is risk of embolization. Second, there could be peri-device leak. If you use a too much big size, then it becomes strawberry shaped. Although when you look at it, it looks more comfortable. The hooks are not actually released here. So this is not the most stable position. The stable position is ideal position. So always target this position when you want to deploy. So I'll just be presenting this case. This is 78-year-old gentleman, diabetic, MI, on antiplatelet, has CKD, not on dialysis, but creatinine is high, has AF, history of recurrent syncope, and bleed on intracranial, on warfarin. Patients on CKD, most of the time they are not on any, they have to be on warfarin. With history of bleed, this patient is not suitable for any oral therapy, so hence would be ideal for left atrial appendage closure. As we keep discussing, again, the very important thing is the septal puncture. So all of us, time has come that all of us need to learn septal puncture under TE guidance. As you heard the previous speaker talk about, mitra clip, it's very important to learn the proper septal puncture under TE guidance. So you need to take to bicable view. Puncture is done in AP. Half the heparin is also given because you're very confident of your puncture. And once you do that, the tenting could be seen. So for this, the puncture is posterior inferior. That means in bicable view, you are in the thin part of the septum, but you are inferior. You are in the lowermost part. Then you ask your echocardiographer to go to aortic view and you rotate your catheter clockwise. By doing that, you go away from aorta, hence posterior. You can see the tenting and you can do the septal puncture in AP. If it slips much, there are other techniques can be used. Once you enter LA, measure LA pressure. It has to be ideally more than 10. If it is not 10, this is the time to hydrate. And if you're not able to, even after that LA doesn't increase the pressure, then we tend to upsize the device very little. Then once you do that, you're already in left atrium, then the changes. Ideally, at this point, it's better to enter pulmonary vein and then use the implanza wire and exchange it to 14 French sheath. You can also exchange these things in appendage, but as I was repeatedly, appendage is a very thin structure. So exchange the sheath in left upper pulmonary vein as it is seen. So in this lower image, the sheath is already 14 French sheath is already in left upper pulmonary vein. You have loaded the device, which is 2 to 3 millimeter more than the landing zone or the neck diameter, and the device is now being taken into the appendage. So now again, if you see, just concentrate on the lower fluoro, you see that we have made that gola and beyond, and now the whole system is pulled down. You're not unsheathing, you're just pulling the whole system down. You realize that the system, it actually enters left atrium. And now when you push, you're entering the appendage, and that can be confirmed in echo. Echo is very important here. Most transmitral intervention and appendage, it's a two-person procedure. You need to have a good echocardiographer. Now we know that we are already in the appendage and we are comfortable. This would be the position where you are going to land your device. Now you start unsheathing. You maintain an anti-clockwise torque and sharp unsheathing. So as you see in this picture, you are maintaining anti-clockwise, and as you unsheath, it becomes a triangle, and you visualize that triangle in the echo. You're happy with the position. Continue to maintain anti-clockwise torque and unsheath. So 2 number clockwise during septal puncture and anti-clockwise during device deployment. As you do anti-clockwise, you realize you understand where the position is. You keep looking at the echo, and further unsheathing will actually release the disc. So if you see this and you are constantly monitoring in echo, finding out whether your position is fine, and you realize here that your disc is fine and your uh, lobule is fine and it's released fine. So if you see that the device is compressed here, there is good separation. Most of the time this deployment is done in RAO cranial view for these devices and RAO caudal view for watchman device. And here lower down we can see the wiggle. This wiggle is not as vigorous as our ASD wiggle. It's more like a straight to stretch, and you see that the device is not moving independent of appendage, and it is fine. And you look at the echo and you're fine. So once you're sure, and in echo if you're comfortable, the device is now it's tire shaped, there is good separation, and it doesn't move too much with the wiggle, just the disc is moving but not the lobule, and you release the device. As you release, see the position here, it looks very good. It is positioned where we want it to position, and the disc is completely occluding the atrial appendage. You're looking at the upper pulmonary vein and its flow is good. And once you this is when it is released, and once this gets endothelized, LA is excluded from circulation. We don't like to have peri-device leak in current era. So most of the time, by sizing the device properly and by positioning it properly, the peri-device leak is now minimized. You need to ask your echocardiographer to decrease the gain to see whether the flow, you have any flow peri-device. If it is not there, that's the right position. Little bit flexibility is always present here. You could reposition it once or twice. These devices are easier to reposition, so you can get the appropriate size and do it. Like any other, it's just a venous puncture, so the sheath is removed. Usually figure of 8 is put. Good heparinization, 50% of the heparin even before septal puncture. As soon as you do septal puncture, you give more heparin. Like any other procedure, complications are possible. Air embolism is important. That's why the hydration and most exchanges underwater. Most common complication is actually pericardial effusion. So be very delicate, respect left atrial appendage. Do not do unnecessary exchanges or unnecessary movements inside the appendage. As much as possible, do the exchange in pulmonary vein, especially in the first 10 cases. Once you understand, you could do some of these exchanges in appendage itself. No arterial puncture, hence peripheral complications are minimal, and you don't need to use contrast most of the time. Hence, again, renal failure, renal dysfunction is uncommon. But we need to be vigilant and we need to be careful, monitor the patient for pericardial effusion even post procedure. Typically, these patients are given dual antiplatelet for 6 months and a single antiplatelet after that. If the patient has received Watchman, then as per PROTECT trial, they did use warfarin for 45 days. If the patient tolerates warfarin, you could give for 45 days. Most of the devices, it's just dual antiplatelet, which is given, single after that. So thank you for patient hearing.
Thank you very much, Dr. Ranjan Shetty, for that fantastic overview of LA appendage closure. I think we'll kick off our discussion today with none other than Professor Sondergaard, who is an authority, who has published several papers. I'd like to invite your comments, sir, Professor Sondergaard, on LA appendage closure on the talk today, and probably LA device appendage closure in the third world.
Yeah, it was a great talk, great overview of where we are today, and you can say there's different indication if you look how it is in Europe and in the US. In the US, it's approved for patients who can tolerate oral anticoagulation but at a high bleeding risk, whereas in Europe, it's mostly used in patients with absolute contraindication against it. One of the one of the missing evidence we got today is how is left atrial appendage closure doing against NOAC. So remember, the protected AF and the PREVAIL trial was against vitamin K antagonist. So there's two large-scale trial now going on. Abbott got the Catalyst trial and Boston Scientific Champion trial. And I think those two trials potentially can make a much bigger impact for this procedure, which is still quite limited in number when you take into account how many patients who actually could potentially benefit from this procedure.
Great indeed. Professor Rajesh, could you provide some insight and comments?
Yeah, great lecture from the master. I have two questions to Ranjan. First is, after the recent Amulet ID trial, do you have any specific preferences for any particular device like Watchman or the Amulet device? Second question is, most of these patients are having high CHA2DS2-VASc score and a very high HAS-blood score. They would be contraindicated for anticoagulation. What is your regimen after you put the device regarding the risk of delayed thrombosis and residual flow after putting a device?
Yes. Thank you, Dr. Rajesh. I think choice of device is it's a tough call. There are some cases where Watchman cannot be used because if the depth of the appendage is not too much, if it's less deep, and if there is already some deep set or some clot, these are the things where you do not want to use Watchman. Any other device is fine. Any fresh clot in left atrial appendage, we actually don't prefer to do the device at that time, but a tiny bit of clot, very distal, lamprey might become a better device because it has a covering and you're actually starting in LA and you're entering in. Cost also is a concern when you choose different device. Watchman has lots of data, so it's preferred definitely in a person whose appendage is deep enough. So I would give this option, but it typically costs double the other devices which we use. Now, post device implant, as Professor Lars did mention, depends on the indication which is used. So in US, since it's indicated in people who can take anticoagulant, so their regime is typically 45 days warfarin, followed by do a DE. If there is no peri-device leak, shift to dual antiplatelet for 6 months. But that is for Watchman. Any other device does not require anticoagulation, and the recommendation for other devices is only antiplatelet. If you look at real world data, which is Evolution Registry, which probably has one of the large data of Watchmen in real world, 60% of the people were actually just on aspirin and it didn't matter, they did not have too much stroke. So post device, I don't think so we need to give anticoagulation. And you were also mentioning about peri-device leak. It's less now with more experience and learning how to use device with most devices. Right now in current era, the peri-device leak is much less. Any leak probably less than 3 millimeter probably doesn't matter, but we are not very sure. So the best time to prevent leak is while implanting. So as much as possible, try to have zero leak.
Okay, thank you.
Dr. Arun Gopi,
we have two
electrophysiologists in the panel. So
here,
from that angle, any comments?
Thanks, sir. It's always wonderful to listen to you. It's always like watching a live case. Pleasure listening to you for many years in learning from you. So just quick 2 points actually. What are your experience with the issues of device-related thrombosis? Many reports coming up on the follow-up, and how do you deal with it? And any issues with the LA function, mechanical function, does it have any impact with the device closure?
Yeah. So I think going back to the device-related thrombosis, yes, it is seen. If you look at the world literature, it could be 3 to 4%. So we need to be vigilant. So as much as possible, 45 days DE is useful to do that. If you If we find it, what I tend to do is, although some of these people do not tolerate anticoagulation at all, I tend to still give them a short anticoagulation with one of the NOACs, even little lower dose may be okay. Most of these people do tolerate anticoagulation for a short period, maybe 1 month, 2 months. They tend to, take it and not have major issues. So we need to, that's the only way to manage it. So around 3 to 4% is what we see. Yeah. And the second question was LA function, right? Yeah. So, but that I think I'm sure you'll be the better person to answer. Sometime during your AF ablation, you all tend to isolate LA completely, and there is also now data with surgical ligation, surgical clipping. So, little exclusion of LA function probably should not matter in today. Yeah, shouldn't matter.
Actually, from our side, initial attempts of isolating the LA electrically was not with good results, because it led to more thrombus, because once the LA was isolated electrically, it didn't go well on the long term. So we are not much in favor of LA isolation, although
so what you should do, I think what you should do is you should put a device. If you isolate LA, I think you should put a device. It's more thrombus issue, so better to exclude it completely if you isolate it. Yeah.
Dr. Praveen, some comments from your end.
Yeah, Natak. Yeah.
I think you're muted, Dr. Praveen.
Ranjan sir, thank you for helping us for our initial cases. Nice hearing you for a long time. And one question, do you use ice? We had used 1 or 2 ice for punctures. So this could avoid GA, because we had to use it because the patient was not stable for a GA, multi-stroke. So do you use ice for?
Yeah. No, that's a good question, Dr. Praveen. I have not used ice. Ice can be used, but then there are 2 aspects to this. One, septal puncture is done. Ice demonstrates it beautifully. Most of the time, you might need a CT to be very sure about LA size if you are using ice. Even if you are using ice, you need to take the catheter to left atria. Only then you get further imaging.
That's what I mean.
It can be done. I have not done it. And the other point is your worry of GA. We use now Dexmed as a drug, which is alpha-2 agonist, and we are not doing any of these cases under GA. It can be done well. All you need is a TE. If it's difficult to tolerate, a pediatric TE probe also can be used. That does give a good image as far as septal puncture and device is concerned. But yes, ice has a role. If it's available, you should use it. Yeah.
We had to use it because the patient was a multi-stroke dementia patient.
Okay.
So there was a laryngospasm. So we could not even negotiate a small TE probe. That was a practical issue.
Yes.
Great points there. We have with us Dr. Alapat, a senior neurologist here from Calicut. Dr. Alapat, your comments on how comfortable or which would be the patient you would send to an interventional cardiologist or a structural interventionalist for this particular procedure. Any comments from your side?
Good evening, everyone. I'm a stroke neurologist, so most of the time, most of what has been said is above me. But talking about patient selection, from our side, we have 4 categories of patients which we send or which we consider for a potential left atrial appendage closure. One is the patient who has bled and who requires anticoagulation. Second is the patient who has not bled, but when we start anticoagulation, we are afraid he's going to bleed. And third is the patient who is having no risk of bleed, but he is supposed to be on anticoagulation. And there is also a subset of patients that can benefit in these. And the fourth is patients who are having recurrent stroke and still on anticoagulation. So these are the 4 categories, and out of these categories, practically speaking, in our referral patterns, the patient who has bled on anticoagulation is definitely referred. But the other 3 categories, we have to identify the subset of patients who will benefit, and practically also it is difficult to convince a lot of patients for a procedure for what he has not had any complication regarding that. And especially a lot of us chronic kidney disease patients who are having recurrent strokes and they are having AF They are having other disease pathophysiologies like intracranial atherosclerotic disease and other cardioembolic due to low ejection fractions or whatnot, or atrial arrhythmias. So these patients, even after the closure, if they develop a stroke, that is also a issue. So overall, we tend to refer patients who are having who has had a blood and who has had a bleed and is a contraindication for anticoagulation.
Point well taken. Fantastic insights. I think we'll go on to the next topic. I request everybody to stay on to the panel. The next topic is on PFO, current evidence in patient selection. Dr. Anil.
The talk, I welcome Dr. Shafeeq Mattummal, the course director, to give the speech.
Thank you so much. I will, in the interest of time, I'll directly go to the presentation. So we all know that role of PFO in many diseases has been debated and has been discussed over the last 20 years. And now we are coming into a lot of new information from the recent trials. So the persistence of foramen ovale is seen very commonly, almost up to 25% in general population. Most of the time it is discovered by chance and may not carry any clinical relevance. A causal role is attributed in cryptogenic stroke, migraine, platypnea orthodeoxys syndrome, decompression sickness, and rarely systemic embolism, which can cause myocardial infarctions like that. So in my talk, I would like to restrict to cryptogenic stroke as per the session. So before we label as a cryptogenic, we need to rule out all the conventional risk factors and non-conventional and rare possibilities which can give rise to stroke. So among these, small arterial occlusion, paroxysmal atrial fibrillation, arch atheromas, inherited thrombophilias are extremely important before attributing PFO as a cause for cryptogenic stroke. So the stroke worldwide is having a high prevalence, and you can see that almost 3.5 lakhs of people are likely to be having PFO in the stroke. So and prevalence of PFO, as we discussed earlier, in healthy people is almost 25%. So the amount of patients who can be potentially treated for recurrent stroke or who can have a prevention of stroke is huge. So that's the importance of having understanding and going through scientific research. So PFO likely is responsible for 5% of all ischemic strokes and 10% of all ischemic stroke in young and middle-aged adults. Cryptogenic stroke makes up to 15 to 30%, and in some series even higher, with a higher proportion in the younger group. PFO present in 40 to 50% of young or cryptogenic ischemic stroke patients versus less 10 to 15% in control. In one of the early series, the prevalence of PFO without an identifiable cause for strokes in young was almost 50%. So that from that onwards, we started discussing PFO as an attributable cause for stroke. Now, this is a ROP score, a risk of paradoxical embolism score, which takes to consideration of the conventional risk factors, actually the absence of it, then a cortical infarct. It should not be a small infarct or a lacunar infarct or a small vessel infarct, and more importantly, the age, and it scores from 0 to 10. So anything beyond 6 or 7 is significant in terms that we can attribute that stroke to PFO. Of course, it doesn't consider the anatomical factors of PFO, which we need to consider separately, like a high risk features, like more than 2 millimeter in diameter, atrial septal aneurysm, and a hypermobile IAS. So in this, you can see that if the ROP score goes up, the percentage of PFOs detected also increase, and the risk of attributable risk also increase. From then, there has been a lot of studies till in the next 14 years, 20 years, and we did not get any conclusion about whether we can link a PFO to these strokes. So the important trials were Closure, PC, and Respect. And Closure study was done in 2012, and it utilized Starflex device. And PC trial, it was a slightly underpowered trial. It used Amplatzer PFO occluder, and Respect trial, which again used Amplatzer PFO occluder. All these did not show convincingly that PFO closure is superior to medical therapy alone. But on extended follow-up of Respect trial, we did get some data. So based on that, from that point in time, 2012 to 16, most of the society's guideline recommended continued medical therapy in those patients even when PFO was detected. But later, new data started coming in, and there were 3 positive trials which were published in 2016 and 17. One was Respect extended follow-up and Reduce trial by Dr. Sondergaard, and Close trial. So these 3 trials came with a positive outcome. Respect extended trial, they found that benefit in favor of closure as compared to medical therapy alone. Respect, as I said, actually used Amplatzer PFO occluder. The Close trial actually used almost all the devices, but mainly Amplatzer PFO occluders, and this also actually gave a positive result where it was found superior to medical therapy alone. Gore Reduce trial used a Helix septal occluder or a Cardiform septal occluder by Gore, and again convincingly showed a significant reduction in stroke in the device arm as compared to the stroke on medical arm. Defense PFO trial was from Korea. They used Amplatzer PFO occluder. This was actually done only in high-risk PFO, anatomically high-risk PFO, and they also found that there is significant reduction in primary endpoint in device group. So a meta-analysis of all these trials in 2018 concluded that it favors PFO closure over medical therapy alone in decreasing a recurrent stroke. So this is the timeline of those studies, research done in PFO. In 2000, the initial Cardiology occluders were approved, and the next 10-12 years we had studies going on, but later on no societies, no guideline recommended PFO closures. But at the end of 2016 and 17, we started having positive trials, and by that time the FDA approved PFO occluder, Amplatzer occluder, and 2018 they approved Cardioform septal occluder as well. So we have now guidelines from various societies, neurology as well as cardiac societies, almost have reached in a consensus that PFO closure is beneficial in those patients who are less than 60 years with a large shunt or with an anatomically abnormal septum like atrial septal aneurysm. Those with the small or moderate shunt, if the ROPE score is more than 5 or 6, again the PFO closure can be is considered. And other clinical subset, we can use our clinical judgment to select the patient. This is consensus from the Asia Pacific region. More or less it was similar, and here even a patient over 60 years who's biologically active in good condition with a PFO, if there is no attributable other cause for stroke, may be considered also for device closure. Similar lines of guidelines were published by AHASA also. American Academy of Neurology gave a detailed guideline recommendation in 2020 to recommend PFO device closure. considering the data that came in last 3 years, and also emphasizing the continuing research follow-up and the operator and the center experience to be emphasized. And similarly, the Sky actually published a statement for operator and institutional requirements, so that PFO closure should be considered in centers where and operators who do structural interventions regularly. So how do we clinically evaluate? Typically, the patient reaches a stroke specialist. Stroke specialists, when they analyze etiology of stroke, they tend do transcranial Doppler if there is no obvious cause for typical cause for stroke is found. And you can see on the left panel the transcranial Doppler in various subset. In the first line is a normal one. In the second, you can see scattered hit. In the third one, more frequent. And in the fourth one, you can see a curtain-like hit, which suggests significant embolization. You can see that after that, we take the patient for transesophageal echo to actually look at the defect, assess the sizes, position, see the anatomical abnormality, and do a physiological testing like Valsalva and how the septum moves, and then do a bubble contrast test. You can see that there is significant shunt when at the release of Valsalva, and suggesting probability of stroke coming from this. This was the high-risk anatomical factors where we should consider closure of PFO, as evidenced by the defense PFO trial: atrial septal aneurysm, presence of a eustachian valve, resting right-left shunt, a large PFO shear network, and long tunnel. All these increase the risk of a right-left shunt. Procedure is typically done in local anesthesia. It's only a venous procedure. Imaging guidance is actually preferred. It may not be possible all the time, because if we have to give a transesophageal, you may have to give a prolonged conscious sedation or a general anesthesia. ICE-guided procedure can be done in local anesthesia, but will require another venous puncture, a large bore venous puncture on the contralateral side, and obviously it is costly. We actually tend to do fluoroscopic and transthoracic. This is a very helpful feature that we see on fluoroscopy, Pacman sign, as described by Dr. Bernie Mayer. After deployment of the device, the cranial portion of the LA and RA disc just stay in such a way that it resembles the old Pac-Man game. It just says that the sectum is well caught between the two discs, and the injection actually is not a common practice, I guess. This can actually delineate just the position of the RA disc in the RA and in the lever phase. You can see that LA border and LA disc is there. This is another high-risk PFO. You can see the hypermobile septum with a lot of right-left shunt on injection of bubble contrast. This patient was treated with a Amplatzer device, and on the right panel you can see that it is a bubble contrast study after 6 months showing no shunt, and this was a 27-year-old lady. So we stopped antiplatelet after that. Typically we do transthoracic echo on discharge on the next day, 1 month, and transesophageal at 6 months. Currently we have devices. Most of the devices actually are a double disc design. These are the devices that are approved by FDA. Amplatzer is the most common device. The Gore, Oclotec, and Ultracept are not available in India, and there are some suture-based device also to close PFO in those cases who are not suitable for any device type. We have Amplatzer, PFO occluder, and Cocoon and LifeTech, which are quite similar to Amplatzer. The most commonly used is Amplatzer. However, there are still some unanswered questions in PFO device closure. What is the optimal antiplatelet or anticoagulation regimen, balancing the risk of recurrent stroke or embolism against the risk of bleeding? And there was no benefit for oral anticoagulation with vitamin K antagonist in some vitamin K trials, And what is the duration, optimal duration of dual antiplatelet therapy? We are comfortable in doing on a fluoroscopic with a transthoracic echo approach, but we need to prove the safety and efficacy in terms of detecting a residual leak. There were reports of new atrial fibrillation in certain trials, and we need to actually see on long-term follow-up what is the relevance of that atrial fibrillation. It is it is not uncommon to detect a high-risk PFO in a routine general checkup. Sometimes those who aspire to be in the sports and all. So, should we close the PFO to prevent the first stroke? And that's again a doubtful scenario. So we don't have answers to this question. A patient with inherited thrombophilia and have a PFO, so should we do a prophylactic PFO closure? There has been many studies in migraine, but we still don't have a conclusive evidence to say that PFO device closure can prevent migraine. So my take-home messages will be like this. PFO device closure now has evidence of superiority over medical therapy in selected cases for prevention of cryptogenic stroke, which can be attributable to PFO. Exhaustive investigations are required before we label cryptogenic. Arrhythmias has to be ruled out, small vessel disease has to be ruled out. Multidisciplinary teamwork involving a stroke specialist, imaging specialist, and interventional cardiologist is likely to improve the process of patient selection and thereby clinical outcome. Minimizing complication is the key during procedure. T and ICE guidance is highly recommended, though may not be practical, at least in our part of the world. A bubble contrast study after 6 months may guide us further to consider and improve the medical therapy and whether or not we should alter or stop the antiplatelets. And finally, operator and center should have sufficient exposure in training in structural intervention and should continue to acquire skills and knowledge of the new devices which are coming to market. Thank you so much for your patient listening.
Thank you very much, Dr. Shafeeq. Fantastic overview of PFO closure. I think we've got a lot of questions to be answered. Again, we'll start the ball rolling with none other than Professor Sondergaard. For those of you who don't know, Dr. Lars Sondergaard was the chief investigator of the GO Reduce trial, published in 2017 in NEJM. I'll have a question for you, Dr. Lars. Why do you think it has taken so much time? Dr. Shafeeq showed a timeline from the first few studies till now for it to be accepted into clinical practice and coming into the guidelines. Your comments, sir?
Yeah, as always, the critical point is patient selection. And I think some of the trials which was done initially wasn't careful enough about selecting the patients. So some patient who had a TIA, these patients didn't undergo a brain imaging to confirm they actually have a corresponding lesion. That was one of the key issues with it. So I think what was actually happened in 2017, you saw trials was published which was much more rigorously designed and executed.
Correct. Professor Rajesh, would you like to?
Yeah, a great lecture by Shafeeq. One confusion in my mind always remains, if I have a small PFO or a moderate sized PFO, how is device closure superior to the newer oral anticoagulants, NOACs? We don't have evidence to say comparing NOACs versus a PFO closure in moderate to small PFOs. So I would be more comfortable treating them with NOACs rather than putting a device in a small or a moderate sized PFO.
Yeah, a good question. Actually, that is one area where we need a lot of research because we still don't have data on NOACs versus device closures. But having said that, it is important to identify high-risk features, even though it's a small stroke, and it's the kind of age group and the kind of stroke that a patient developed. So the ROPE score actually helps here in deciding whether or not we should be considering PFO or whether we can attribute this PFO to the stroke. So if the patient has had a significant major territory stroke and there is a PFO and is a young patient, that itself takes the ROPE score above 6 or 7. So at that time we have something like 70 to 80% probability of attributing that stroke to the PFO. So in such patients, they'll be benefited by PFO device closure. But again, comparing this with a NOVAC, we still don't have data. Dr. Lars, would you like to comment on that?
Yeah, just remember the mean age of these patients are around 40 years. So committing a patient on 30 or 40 years of anticoagulation instead of a procedure which is very simple and at a low risk, I think you have to consider whether this is reasonable.
Point well taken.
Yeah, Dr. Paul, do you do this thrombophilia screening for all young patients? What is your approach to young stroke?
You're muted, Dr. Paul.
Yeah. In young stroke, we always do the thrombophilia screening. That is for patients who are less than 45 years. Previously, the cutoff was 55. Now we take it as 45 years. And for all these patients, we do a thrombophilia workup. And along with that, we also, even though there is no history of any connective tissue collagen vascular disease, we rule out any of those diseases. We routinely do all the mutations like factor V, prothrombin mutations, the protein C, protein S levels, etc. And we also do a echo and an extended loop monitoring. And after all this, we also have we do a transcranial Doppler, and where after a transcranial Doppler, if we can demonstrate hits on the transcranial Doppler, and we also grade the hits according to the classification system. And we refer to a cardiologist if there is no other cause and if the hits are positive. But there are also a subset of patients in which, even though the ROPE score is low and there may be a curtain of hits, we can assess the severity in the transcranial Doppler, and that also we refer to the cardiologist for assessing. For us, actually, from here, because of a large patient load, the difficulty in getting a transesophageal echo has actually motivated us to do the transcranial Doppler, which is a easier, less invasive test. And always we have found out that it excellently correlates with whenever we have got a hit on a transcranial Doppler, it has not failed to not show up on the transesophageal echo. We have never had an instance like that.
So you would do a transcranial Doppler for all strokes, or only the cutoff
We do
which you
for young
mentioned
strokes
45?
We do for young strokes and recurrent strokes on best medical management. And we also do an MR angiogram, so we get a feed of or a CT angiogram of the intracranial and the extracranial vessels. So if those vessels are also normal and there is no cause, it is not a large vessel stroke, and it is also not a lacunar syndrome or a lacunar stroke, and there is no cardioembolic etiology, then then it is a cryptogenic stroke. So in those cases, we go ahead with irrespective of the age.
That's an interesting point. A lacunar stroke is unlikely to be an embolic stroke. Is that right?
Yeah, lacunar by definition, the radiology, there is a lacunar definition, and there is also a syndrome of lacunar definition in stroke. So if it fits the syndrome of a lacunar stroke, clinically, radiologically, and risk factor wise, it is a lacunar stroke. But maybe in MRI reports, you will see a lot of small infarcts being labeled lacunar. That necessarily is not lacunar, it may be cardioembolic also.
Fantastic points there. Dr. Arun, any insights, any comments, please?
Dr. Shafeeq, wonderful talk. What is the mechanism of, two questions actually, what is the mechanism of AF post PFO closure, and how comfortable are you stopping antiplatelets in a cryptogenic stroke after 6 months, even if you find nothing on the bubble contrast study?
Couple of trials actually showed early atrial fibrillation after the device closure, but on follow-up it was not seen further. And
what's the mechanism?
Mechanism, it was actually device related, but in the follow-up nothing else was seen. So another thing, the second question was about stopping the antiplatelet therapy. So in a young patient, if there is no attributable, any other comorbid risk factors, and if there is not residual shunt, in stroke. Residual shunt in the 6-month transesophageal echo, we are very comfortable in stopping antiplatelet. If there is no family history, if there is no other rare syndromes also to predisposed to thrombophilia, we can comfortably stop.
Dr. Praveen, final comments?
One thing, Shafeeq, it was a very good presentation. I really enjoyed it. One concern is, suppose by the age of 30, 40, they have closed a PFO. Later, you find that there is a paroxysmal AF. For example, it's a so-called cryptogenic stroke. But later, they develop it might be difficult for AF interventions later. Probably you may have to resort to medical management.
Actually, you can still do transeptal puncture. Another aspect here is atrial fibrillation. Atrial fibrillation, I didn't get your question, Praveen.
Suppose it's a paroxysmal AF, later patient develops AF, it might be difficult for left atrial interventions after that.
Because of the device?
Hmm.
No, actually, you can still do transeptal puncture around the
device puncture.
Yeah, not device puncture actually. Around the device, you can still do the transeptal puncture. Dr. Lars, can you enlighten us?
Yeah, that's right. You can puncture next to the device, and there's also been case report where people have actually gone through the device, which is of course a little bit more difficult, but it is possible. And of course, that's a concern when you put something into the atrium, that you need to be aware that it may be more difficult or suboptimal puncture afterwards.
And one comment that I would like to make is most of these trials actually monitored for atrial fibrillation for 1 month. We clinically almost always do 1 day or 3 day Holter analysis. So before they rule out atrial fibrillation as a cause of stroke and label it as a cryptogenic, they did 1 month in trial. Dr. Lars, is it a practice clinically out of the trials also to monitor these patients for 1 month for atrial fibrillation?
I would say I got this practice in my institution that I'm not the gatekeeper. It's a stroke neurologist who's going to do the workup and set the indication for PFO closure. And only if that happens, I will close the PFO. And it's different from site to site, whether it's a 24, 48 hours, maybe a 1 week monitoring for AFib, but that's certainly something which is very important to rule out in these patients.
And how do you choose between these devices out of a trial setup?
I think if you look at the two main devices used, the Amplatz PFO occluder and the Gore Helix or now Cardioform, the effectiveness was actually the same. Complete closure in around 75% and effective closure, that would say a shunt less than 25 bubbles coming across, in 95%. Was that different in the rate of post-procedural atrial fibrillation? That's difficult to answer because in the reduced trial with the Gore device, there was more time point where the patient was actually screened for post-procedural AF compared to the trials using the Amplatz device. I would say most of these AFib is coming early on and they're cell limited. But again, it can be a major issue. There was one patient in the reduced where it actually led to a stroke.
Great. We had a fantastic session here on stroke prevention. A lot of points covered from our cardiology and our stroke neurologist colleague here. I think we'll close this session. I take this pleasure to thank our speakers, Dr. Ranjan Shetty and Dr. Shafeeq. Very warm thank you to all our expert panelists, Professor Rajesh, Dr. Alapat, Dr. Arun Gopi, Dr. Praveen, and Dr. Lars. With that, we'll close this session. Thank you very much. I request Dr. Lars to stay on. We now move on to the next session, the exciting session on structural interventions, TAVI. For that, I take this opportunity to invite our expert panelists. With us, we have today Dr. Ashish Kumar Mandle, Chairman and Senior Consultant Interventional Cardiologist and Structural Interventionalist from Maitra Hospital, Calicut, Kerala. We also have Professor Bijulal, Professor and Senior Cardiologist from Sri Chitra Institute, Trivandrum in Kerala. We have Dr. Thomas Pilgrim, consultant and structural interventionist from Bern, Switzerland, and Professor John Jose, professor from Christian Medical College, Vellore, Tamil Nadu. A warm welcome to all our expert panelists here today. All right, so we will go on to our first topic of this session, of the TAVI session. And to speak on this, we have none other than the expert, Professor Lars Sondergaard, a person who needs no introduction whatsoever. Dr. Lars Sondergaard is a professor of cardiology in the Heart Center and University of Copenhagen in Denmark, a person who's had a lot in innovation and research in all the gamut of all interventional and structural interventions, from valvular as well as congenital and structural heart disease. I'll pass over the session to you, Dr. Lars, to talk on the evolution of TAVR.
Thank you, and also thank you for the kind words. So I'm going to make this presentation with a little bit of historical background, starting many years back, and say, also show how TAVI actually evolved. And I'm going to show some of the shortcomings of TAVI today and how we have seen device iterations and also procedural optimization to try to overcome it, and look a little bit into the future for this technology. So, I mean, you have all seen this picture here. It's Wilhelm Röntgen back in 1895 by an incident actually discovered this, what he called X-ray. And a few days later, he had this X-ray of his hand's wife. You can see the wedding ring here. And he actually knew what he was doing, and very soon got an understanding, and it didn't take a long time before X-ray was into clinical practice. And for many years, it evolved, but I mean, the quality is actually the same, and many of the procedures we're doing with X-ray is the same as it used to be. This is a chest X-ray. I think that's normal practice in many institutions. And even though it's maybe not the best quality, there's an explanation for that, because this X-ray is almost 100 years ago. It was done in 1929. It was not a patient. It was a young physician, Werner Forssmann. At that time, there was a lot of discussion whether you could do examination of the heart by putting catheter, putting lines into the heart, but most would consider this as a life-threatening procedure, that it would cause arrhythmia and sudden cardiac death. But again, this guy wanted to try to examine it, but it was, of course, hard to find anyone who's going to volunteer for it. So what Forssmann did was that he actually took a line and introduced it through the venous system into his own right atrium. And he walked through the hospital to the X-ray department and had this X-ray taken of his own chest with this line into it. And next he went up to his chief, Dr. Sauerbruch, and showed very proudly his X-ray and was expected to have some recognition for it. But what actually happened was that he was fired, he was sacked, and he never again worked within cardiology. And you can ask, why did Sauerbruch sack him? And one of the reasons was that Forssmann could not really explain what he was doing and what was a clinical perspective of it. So Sauerbruch thought this was a maniac and he couldn't have this guy in his institution. But as you all know, years later, 27 years later, Forssmann was actually receiving the Nobel Prize and is today recognized as one of the fathers for intervention cardiology. And years later, in 1977, after heart catheterization was mostly used for diagnostic purpose, you all know Andreas Grünstig did the first PCI, inflating a balloon in coronary artery disease. And later on in 1986, this was actually further developed using coronary stents, which was more effective than just balloon angiography. The reason I'm showing this, that when this was launched, there was a lot of attention about it. And there was a young Danish cardiologist, Henning Rud Andersen, who attended one of these meetings, actually with Dr. Palmas, about using stents in the coronary arteries. And on the way back in the flight from the US to Denmark, he got this idea, maybe you could all have a heart valve inside a stent and use it as a valve replacement. And you see here Henning standing here with his idea in his hand, looking very optimistical. And you can see this old guy in the background. We can come back to that guy in a few minutes. So what Henning did was he went down to the butcher, he bought a pig's heart, explanted the aortic valve for this heart. He made his old stent from sternal cerclage, which from the surgical department, and crimped it on the balloon, as you can see here. And he actually succeeded already back in 1989 to implant these valves into a pig model. And he was very proud of that. So he contacted all the valve companies and tried to understand when anyone was interested in his idea, but all of them turned it down. He also wrote a manuscript on this, and it was submitted to circulation, to JAC, all rejected up front. And finally, 3 years later, it was published in the European Heart Journal. So again, at that time, no one saw any future for transcatheter heart valve replacement. The patient was sold and ended up with Edwards, and in 2002, as you know, the first in-human TAVI procedure was performed by Alain Crébier in France. And what actually happened was that Henning, later on, he treated that old guy you saw in the back of the picture. It was his old dad, who later suffered from severe aortic stenosis. So Henning did a TAVI procedure with this Edwards valve in his own father, which is, I think, very beautiful ending of that story. So ever since, there's been two dominating transcatheter heart valves on the market. There's a balloon expandable valve, which is based on what Henning developed back in 1989, and then self-expanding technology, where you do not need a balloon because the stent is made from nitinol and will expand up when it's coming out of the catheter. And one of the difference with these valves is that with self-expanding technology, for most of these valves, it's actually possible to recapture it. So if you don't use a balloon expandable valve, you have one go. When the balloon is up, you cannot really regret where the position is, and you have to deploy it. But for the self-expanding technology, you can deploy the stent frame about 80 or 90%. If you're not happy about the position, it's too high or too low, you can change it and then redeploy it, which is, of course, is going to have a more accurate and predictable outcome for these procedures. So again, what are the limitations of TAVI, or what have they been during the years? In the beginning, paravalvular leak was an issue for some of these valves, and it was reported that around 15% of the patient undergoing TAVI had more than a mild, moderate, or severe paravalvular leak, which we know was associated with a higher risk of mortality. And one of the reasons in the beginning was that this patient was worked up using echocardiography for sizing the aortic annulus. And one of the issues with echocardiography is that even whether you use a transthoracic or transesophageal echo, you're going to have the minor axis of the aortic valve, which is not a circular structure, but often an elliptical. And thereby there was a tendency to choose too small size valve for an individual patient, and thereby having paravalvular leak. But that's now changed. Today, all the patient who is considered for TAVI would have a CT scan as a part of the workup, both a cardiac CT scan gated to the ECG to measure these structures and also to see their relationships with the coronary arteries and so on, and a non-gated to look for the access vessel. So for this cardiac CT scan is now, there's a lot of software on the market, so you can decide that you have to find where's the aortic annulus, and when you have the aortic annulus, you can make the perimeter, and from the perimeter you can calculate what is the perimeter-derived diameter of this valve, and thereby have a much better accuracy when you decide which size valve should you use for the patient. So undersizing of this valve are not an issue anymore. The biggest issue for having paravalvular leak after procedure is if you have severely calcified aortic annulus, or as you see in this case, also calcification extending down to the left ventricular outflow tract. That's going to prevent the stent frame to expand fully, and outside the stent frame, you can have a substrate for paravalvular leak. But we have now seen new generation valves coming out with different technologies. Some of the newer ones have an active sealing skirt around here to prevent it. Also this one, the portico valve, is now the Navitor valve with the same. And also the Indian hydro valve also is designed to have a lower grade of paravalvular leak. So paravalvular leak is not really a major issue today. I would say for most of these valves, it's about 1 to 2% of the patient who have more than a mild PVL after a TAVI procedure, compared to, as I said before, around 15% in the beginning of the TAVI area. Another issue is conductance abnormality. So quite a few of these patients will develop new onset left bundle branch block after a TAVI procedure, and also a subset of these patients will have a complete AV block and the need for a permanent pacemaker. The issue with conductance abnormality after TAVI is that you have a very close proximity between the aortic annulus and the AV node. So if you look here on the right and the non-coronary cusp, you have the membranous septum located here, and just below the membranous septum, you have the conduction system. So one of the issues is if you implant your valve too low, it will potentially interfere with the conduction system and cause a conduction abnormality or even need for permanent pacemaker. So nowadays, everyone tries to implant the valve as high as possible, and there's also different rate of conduction abnormality for different valves. So there's been this move to have your C-arm angulation in the cath lab in a classical LAO cranial projection, to move the C-arm down to an RAO caudal projection, what we call a right-left cusp overlap view, because this is a projection you can determine from the pre-procedural CT scan. The benefit of using this cusp overlap technique is that, first of all, you still have all the 3 aortic cusp aligned with the imaging plane, and you often also have no parallax on your delivery system. And finally, in this projection, you have elongation of the left ventricular outflow tract. So these 3 factors mean that you have a much better understanding how deep or how high are your valve implants. So even though you're not aiming for a higher implantation in a cusp overlap view compared to a classical 3-cusp coplanar view, it's going to give you a true understanding on the depth. And we are seeing for most of these valves about a 50% reduction in permanent pacemaker using this view for valve implantation. Also in the beginning, major vascular complication was an issue, and it was the main complication and also the main reason that patient was dying during a TAVI procedure, because the system was quite big. And again, everyone wants to do the procedure as a transfemoral approach because they have the better outcome for the patient. But if you push it too much, you may end up in a situation like this where you have a fatal vascular complication. So again, what we do up front is every patient have a CT scan to look at the access vessel, look what is the size. Are they more than 5-6 millimeter, or are they smaller? Are they very tortuous? Are there a lot of calcium? So you can see here on the left-hand side, there's a candidate, very good candidate for a transfemoral approach, proper size vessel, not tortuous, and no calcium. On the other hand, on the right-hand side, there's a patient who should not be considered for a transfemoral approach. But again, we have several ways for alternative access. We have the transaxillarian access, which is used quite a lot, also the transcarotid, or some sites will even use this transcaval approach. So you go into the femoral vein, go up to the IVC, and then puncture your way into the aorta and put the sheet in, and afterwards you close that hole with a plug. So most patients nowadays, almost all patients, are you are able to do a TAVI procedure, and it's around 90 to 95% of the patient you can do as a transfemoral approach. The remaining around 5 to 8%, you have to look for an alternative access. Also, one way to improve your closure and minimize your vascular complication is to do ultrasound guidance. So you're sure you're going to puncture the vessel in the middle and at a point where you have no calcium. So all these things have done that the rate of vascular complication is much smaller. And also, as I said, we have seen device iterations. Devices are at a lower profile. Some of these devices have an integrated sheet, so you do not need an external sheet. That's going to save you about 4 French in diameter, which is corresponding to about 1.5 millimeter. And some of those devices also have expandable sheets, so the sheet will go in a low profile and just expand up as the valve is traveling through this. Another complication for TAVI has been stroke. And at least in the beginning, it was considered that if the patient underwent TAVI instead of surgical aortic valve replacement, there was a higher risk of stroke. We know that there's several time points where the stroke can happen. It's most common during the procedure itself because you have your delivery system across the aortic valve with manipulation and embolization of calcium and other debris, which potentially can go into the brain. But there will also be, in the first couple of weeks afterwards, a risk of stroke due to non-endothelialization of the valve yet, and also in some of these patients, new onset atrial fibrillation. So there's been a lot of discussion what kind of anticoagulation or antithrombotic therapy to use in these patients. I think for the patient we're treating today, where the mean age is high 70s or maybe even into the 80s, it's shown that less is more for these patients. So if you give them dual antiplatelet therapy, they're going to have a higher risk of severe event, including death, compared to single antiplatelet therapy. And if the patient have a risk, a need for oral anticoagulation, you should not combine it with antiplatelet therapy if there's no other indication for it. During the procedure itself, there's a lot of discussion whether to use these cerebral embolic protection devices. There's quite a few in the markets now. The most common used is the Sentinel device. It's a filter. So it's a 6 French sheet in the right radial artery. You're going up, you place 2 filters, one in the innominate artery, taking the right and the carotid arteries and vertebral arteries, and 1 filter in the left carotid artery. So the only vessel which is unprotected is the left vertebral arteries. And that's going to sit there during procedure. And for almost all cases, you'll see there's a capture of debris. And if the patient is undergoing, if you do MRI scan of the brain for these patients with or without filters, you see that the filter is going to reduce the number of new lesions and also the size of the lesion in the brain. The big question, is it going to change the rate of clinical stroke for these patients? Today, there's at least 2 major trials going on. There's the protected TAVR run by Boston Scientific, and also a big study in the UK, also using the Sentinel device to randomize patients plus minus this device and look for clinical outcome. So that's going to give you much more information about whether to use these filters in all patients, or maybe only a subset of the patient, or maybe in none of the patients. Another issue has been in the beginning, what is the durability of these transcatheter heart valves? As you saw, they're crimped into small delivery system, and there was a concern that that would going to affect the durability. A surgeon would never touch the leaflet of a bioprosthetic valve. But today we know that bioprosthetic degeneration, one of the main factors is that you have patient prosthesis mismatch. So if you put a too small valve into a patient, you're going to have a higher risk for an early degeneration of the valve. You see here, PPM is doubling the risk of valve failure. And also we are seeing that patient prosthesis mismatch is also going to affect the clinical outcome. So if you have moderate PPM, the cardiac-related mortality is about 1/3 higher than if you have no PPM. And if you have severe PPM, it's more than a 6-fold increase in cardiac mortality. So of course we should try to consider which valve is the best to avoid it, particularly in patients with small aortic annuli and thereby a higher risk of patient-prosthesis mismatch. I'm just going to show you that self-expanding technology with supra-anal position is going to give you the best hemodynamics with the lowest rate of patient-prosthesis mismatch. This is the novel valve from India, the Hydra valve, very flexible, big cells, so easy to access the coronary arteries. And also, as you see in the inflow part, it's non-tapered, so it's more cylindric, so we have a lower interference with the conduction system and thereby a lower rate of pacemaker. And as I said before, got this supra-anal position, which is going to provide the optimal hemodynamics. And if you compare, as I said, balloon expandable valve, as in this here, with self-expanding technology in patients with small aortic annuli, 23 millimeter or less, you see that for self-expanding technology, it's around 3% of the patient who got severe patient-prosthesis mismatch, compared to around 75% in patients treated with a balloon expandable valve. So that's certainly something you should take into consideration if you have patients with smaller aortic annuli. Use self-expanding technology. That's going to give you a better hemodynamic and a longer durability of these valves. And I just want to show here one final slide here on this Hydra valve from the Genesis trial, which was conducted in India. So you can see again, low gradient, 6 millimeter mean gradient, afterwards high opening area, 2.3 square centimeter, and also low rate of permanent pacemaker, 7.5%, and more than mild PVL here at 30 days, 2.9%. So that's certainly a valve which is a next generation and state of the art. What about the procedure itself? It started out early on to be almost like an open chest setup in the cath lab, patient in general anesthesia, cardiac surgeons and in the room and so on. But over the years, it's been very simplified. It's like a PCI setup. Patient is fully awake. It's done with only few access. It will take often somewhere between half an hour and 1 hour to do a straightforward TAVI procedure. And the patient will go straight back to the ward afterwards, skipping the ICU. And this is just data from Copenhagen a few years back. You can see the red bars are the hospital stay in the beginning was almost 2 weeks. I would say nowadays more than 75% of the patient is leaving the hospital the day after the procedure and going home to their own home. And it's not being on a cost on safety. 30 days mortality is steady going down. And I think most institutions is now running with a 30 days mortality, not more than 2%, and quite a few sites will have less than 1% 30 days mortality. And also we have seen evidence on this therapy. There's been 7 trials randomizing patients between surgery and transcatheter aortic valve replacement for high risk, intermediate risk, and low risk. And if you do this meta-analysis, you can see that if the patient is going for TAVI, you're going to have a 12% reduction in all-cause mortality at 2 years. And if you only include the patient stratified for a transfemoral approach, it's actually a 17% reduction in all-cause mortality with TAVI compared to surgical aortic valve replacement. And also we know that stroke is also less with TAVI. Again, these 7 randomized trials, so patients undergoing TAVI have a 90% reduction in stroke compared to the surgical groups. So my final slide, what's going to happen with TAVI? This graph here is a few years old, but I think it's indicating that no matter whether you're in Europe, in the US, or rest of the world, the number of procedures is going to grow. So in the next 5 years, it's predicted to be at least twice as common as today globally. And of course, there will be some local part of the world where it's not as developed yet, where the growth will be even more pronounced within the next 2 years. Thank you.
Thank you, Dr. Lars. Nothing short of electrifying. That run through of history of TAVR, those slides, especially the first of Dr. Henning, was really exciting. I think we'll set the ball rolling onto discussions from our expert panelists. Dr. Bijulal, would you like to give us some comments?
It's a wonderful talk by, as usual, by Professor Lars. Recently, I recently listened to a talk by Dr. Ganesh Manohar, where he said in his last 50 cases, he's implanting in the LAO view. That's another newer thing which is coming into the field with a very good result, a very high implant he could obtain in last 50 patients with the LAO deployment. Yeah, now he has probably switched on to LAO deployment instead of RAO quarter deployment. What's your opinion on this, Professor Lars?
Yeah, I think, the key factor for an individual patient for reducing the risk of conduction abnormality is to implant your valve in a high position. And of course, it needs to be without the risk of a pop out. And I think what globally has changed the last year or two is to go away from, as I said, from this LAO cranial projection with your C-arm to this cusp overlap view. There may be other techniques, but again, what it's all about is to have a safe, high implantation. That's going to reduce the risk of conduction abnormalities.
Dr. Ashish.
Great talk from an expert, Dr. Lars. I have a couple of questions. In your presentation, you showed that there is a mortality reduction with TAVI in general as compared to SAVR. Isn't there a similar discrepancy between the balloon expandables and the self-expanding platforms as regards mortality reductions at 2 years? Number one. Number two is you talked about the patient processes mismatch. And the data from the using the Hydra valve is not shared by the Evolut platform because the incidence of moderate paravalvular leak and the need for pacemaker and new onset left mitral branch block is much higher in the studies using Evolut as compared to the balloon expandable platform. And the last question, now the average age of the low-risk patients in most of the trials was in the early 70s. So these patients require a re-intervention, that is for a structural degeneration of the valve. How do you access the coronaries in such patients?
There's three very good questions. First, about mortality rate. Is it different from valve, from study to study, whether it's balloon expandable or self-expanding? I think you can find differences, but also again, it's also about how was the patient selected. So if you look at the latest two low-risk trials, particularly for the PARTNER 3 trial using the balloon expandable SAPIEN 3 valve, patient was really highly selected here. So it needs to be patient who were optimal for TAVI. I mean, good transfemoral access. There could not be severe calcification of the aortic valve. There could be no calcium in the left ventricular outflow tract. Coronary artery needs to have a high takeoff. So that, again, it's difficult to compare from study to study. The only way you can do it is to do a randomized study between two platforms. Second question, what about conduction abnormality for self-expanding technology? That's true. It's been very high with the Evolut platform, and it's also Medtronic, which is mostly driving this move to the cusp overlap view because there's more to gain here. But as I showed you, the rate of conduction abnormality is much slower with the Hydra valve, and also if you take another one, the valve from Boston Scientific, Accurate valve, also have a very low rate. So you cannot group all self-expanding technologies in one group and say they're going to have the same rate of conduction abnormality. It's going to be different from valve to valve. Finally, it's a very good question about what about patient with longer life expectancy, because TAVI was starting out a very old, very sick patient with limited life expectancy. But going to patient with longer life expectancy is going to open up for new challenging. We cannot accept a new permanent pacemaker with the risk of heart failure later on. We cannot accept paravalvular leak. We need valves with good durability and also possibility to revalve this valve. And of course, we need to be able to access the coronary arteries. One of the things which is also a hot topic, which I didn't touch on here, is how to make patient-specific commissural alignment. So one of the issues about accessing the coronary arteries is if you have one of the leaflet posts sitting right in front of the coronary arteries, it will be difficult or in some cases even impossible to access it. So if you can orientate the valve just as a surgeon do, so you have the commissures aligned with the leaflet post of the valve, you're going to have a much easier access to the coronary arteries and probably also better durability of these valves. And will find several techniques here in the literature how to do that, both how to introduce the delivery system, but also with the valve in place in the aortic valve, how to rotate it one way or the other to have patient-specific commissure alignment.
Great points there, Dr. Lars. Dr. John Joes, would you like to comment? You're muted, I think.
So first of all, I'd like to thank Professor Lars for a wonderful glimpse into the history of TAVR technology, as well as a great overview of the TAVR techniques as such. So I'd like to share our Indian experience. In India, both the platforms, balloon expandable and self-expanding technologies are available. For balloon expandable, we have the Sapien 3 and the MyVal. And for the self-expanding, we have the Evolute Pro, Evolute R, and now we have this new entrant, which is the Hydra. And the data which was provided by Dr. Lars seems to be quite promising in terms of the lower rates of permanent pacemaker implantation, and as well as the lower rates of patient prosthetic mismatch. So most of the time, it's the cost which determines what valve gets used in the Indian patient. And in this context, I think both Hydra and MyVal are good options for a large majority of our patients. So in our practice in CMC, we do about 70 TAVIs a year, and we find that both these platforms do quite well in our patients. And some of our rates of permanent pacemaker implantation and other paravalvular leak rates are quite acceptable. My final thought, I would like to ask Lars, in Indian population, the life expectancy is on the shorter side compared to the Western population. So in West, I think the age cutoff for TAVI would be about 65 years. So would you consider reducing that to 60 years for Indian patients, one? And second, in patients with moderate aortic stenosis and those with LV dysfunction or severe symptomatic moderate aortic stenosis, is there a role of TAVI?
Yeah, just answer your last question first. What about indication for patient with heart failure, moderate aortic stenosis, or patient with severe asymptomatic aortic stenosis? I mean, this is still not really in the guidelines, but there's studies going on here which may change the guidelines for these patients. Would I consider to treat a patient at 60 years of age? I don't think we have the evidence for that. Again, remember the two low-risk trials, the mean age was around 74 years of age. Very few patients was younger than 70. And also one important point, and you know that because you're living in India and seeing younger patients, if you move down to younger patients, you're going to see more patients coming forward with aortic stenosis in a bicuspid aortic valve. And remember, bicuspid aortic valve was excluded from all these randomized trials. And even though we know it works, we don't know what's the long-term consequence of doing a TAVI in a 60 years old patient with bicuspid aortic valve. What's the durability? What's the possibility to access the coronary arteries? What's the possibility to revalve and so on? So one thing is to do TAVI in an elderly, high-risk patient with bicuspid aortic valve. We're doing TAVI in younger patient at low surgical risk with bicuspid aortic valve. I think we're not there yet.
Yeah, for the want of time, we are going to the next topic, TAVI for pure native aortic regurgitation. I invite Dr. Thomas Pilgrim, the senior consultant in structural heart disease program of University Hospital, Bern. He has extensive experience in structural interventions as well as TAVR. Over to you, sir.
Yes, so thanks a lot for the invitation to this meeting. Thanks a lot for your excellent talk, Lars. So I will talk about new indications for transcatheter aortic valve implantation with a particular emphasis on TAVI for pure native aortic regurgitation. Let me move to my next slide. So I think during the last 15 years, as Lars has shown, landmark trials generated a robust body of evidence for TAVI in patients with aortic stenosis across the entire spectrum of risk. So this slide summarizes the individual randomized controlled trials. On the x-axis, you see the years of recruitment for these trials, and on the y-axis, you can see the estimated risk according to STS score. However, quite a few patients have been excluded from these randomized controlled trials, and there are some new indications for transcatheter aortic valve implantation. I would like to differentiate between specific anatomic conditions and expanding indications for aortic valve replacement in general. So specific anatomic conditions include bicuspid aortic valve disease, something that we just touched in the discussion, then pure native aortic regurgitation, and eventually TAVI as a valve-in-valve procedure for failed surgical bioprostheses. On the other hand, there are also expanding indications such as expansion of TAVI to younger patients, expansion of aortic valve replacement to patients with moderate aortic stenosis in combination with congestive heart failure, and obviously TAVI for patients with severe aortic stenosis. So I would like to put my talk a little bit into context and would like to give you a brief overview on TAVI for specific anatomic conditions. And we will touch very briefly on bicuspid aortic valve disease and valve-in-valve implantation for degenerated bioprostheses. So let's get started with TAVI for bicuspid aortic valve disease. As we know, a majority or 30 to 60% of patients with bicuspid aortic valve disease do have aortic stenosis or regurgitation in combination with aortic disease, and these patients are not good candidates for transcatheter aortic valve implantation, since you need to replace the aortic root at the same time in a majority of these patients. But in selected patients with isolated bicuspid aortic valve stenosis or some degree of regurgitation, TAVI may be a very effective and safe treatment strategy. Data from the STS, ACC, and TVT registry indicated, however, if you look at peri-procedural outcome, that patients treated with TAVI for bicuspid aortic stenosis as compared to tricuspid aortic stenosis had an increased risk of paravalvular leakage. This may be due to the asymmetry of the cusps and the asymmetric distribution of calcification. At the same time, patients treated for bicuspid as compared to tricuspid aortic stenosis tended to have a slightly increased risk for need for implantation of a second valve. However, if we look at a longer term outcome throughout 1 year of follow-up, data again from the STS ACC TVT registry indicated a comparable mortality rates in patients treated for tricuspid and bicuspid aortic stenosis. These data come from a matched analysis of more than 2,500 patients. Along the same line, rates of strokes were comparable in patients treated for tricuspid and bicuspid aortic stenosis. So in summary, I think TAVI is effective and safe in highly selected patients with bicuspid aortic valve disease with no disease of the aortic root. So let's move to the next off-label or new indication for specific anatomic conditions, and this is the valve-in-valve implantation for degenerated bioprostheses. I think the main challenges of valve-in-valve implantation for degenerated surgical bioprostheses are first coronary obstruction, because the implantation of the second valve may lead to obstruction of the coronary ostia. And the second issue is patient prosthesis mismatch. That has been discussed in the previous talk. And important to note, the manifestation of degeneration of the surgical aortic valve is very important in terms of prognosis. Patients presenting with stenosis as a manifestation of degeneration of the surgical aortic valve tend to have worse long-term outcome as compared to patients treated with a regurgitant valve. At the same time, patients with smaller bioprostheses tend to have worse outcome as compared to patients treated for larger valve. With this, I would like to move to TAVI for patients with pure native aortic regurgitation. Let's get started with this case. This was a 70-year-old male with native pure aortic regurgitation. He had a left ventricular ejection fraction of 55%, dilated left ventricle. The patient had a history of a prior stroke and therefore refused to undergo surgical aortic valve replacement. As you can see on the CT scan, there is a complete absence of calcification of the aortovalvular complex. Echocardiography shows severe aortic regurgitation, as is shown invasively in the aortography. So there are certain technical challenges in TAVI in pure native aortic regurgitation. First, you have suboptimal fluoroscopic visualization of the aortic valve. Then positioning may be complex due to the dynamic regurgitant jet and the excessive stroke volume. So you have much more movement in a patient with aortic regurgitation as compared to patients with aortic stenosis. And there may be insufficient anchoring of the transcatheter heart valve due to absence of calcification. Since patients with aortic regurgitation tend to have larger aortic roots, there may be incomplete sealing of the transcatheter heart valve. This seems to be counterintuitive because these patients usually don't have much calcification, but still, because of the size of the valve, there may be incomplete sealing, which may also be a result from the difficult positioning of this device in this setting. So, since this patient refused surgery after heart team discussion, we decided to offer him a transcatheter heart valve, and this patient was treated with a self-expanding device, as you can see, with a high implantation of an Evolut R valve with acceptable result. If you look at data from a meta-analysis of observational studies reporting on patients treated with a transcatheter heart valve for pure native aortic regurgitation, we can see that the majority of these patients have been treated with self-expanding valves, whereas only about 1 in 5 patients has been treated with a balloon expandable device. Many of these patients were treated by transapical route. We will see in a few minutes why this was the case, and transfemoral access was chosen in slightly more than 1/3 of these patients. If we look at clinical outcome data, we see that the clinical outcomes were worse as compared to comparable patients with aortic stenosis. So 30-day mortality amounted to 7% in these patients. Implantation of a second valve was required in 7% of these patients, and conversion to surgical aortic valve replacement in 2.5% of patients. I would like to show you a second case. This was an 81-year-old male with severely compromised left ventricular ejection fraction of 20%. So he was not a good candidate for surgical aortic valve replacement. Annular dimensions, according to annular dimensions, he is still qualified for transcatheter aortic valve implantation. Therefore, we decided to treat him with TAVI despite complete absence of aortic calcification. This time we chose a balloon expandable device, and I'm showing you this implantation because it's not an optimal result. You see the valve is a little bit deep, and this is actually something that can happen because there is quite some suction during implantation for aortic regurgitation. So this is one of the risks, that the valve tends to be sucked into the left ventricle. So one strategy that may help is to pace a little bit faster in these circumstances and really wait until there is no output whatsoever anymore in the patient, and then only implant the device. So this slide shows data from a multi-center registry including more than 300 patients with a mean age of 74 years and an STS score of 6.7. We can see that absence of device success occurred in more than 1/3 of patients, and this was primarily due to residual aortic regurgitation and need for second valve implantation, which was considerably high. However, if we differentiate between early generation devices and newer generation devices that have some sort of repositionability, that tend to have skirts, cuffs that mitigate the occurrence of paravalvular regurgitation, we can see that clinical outcomes were significantly better in patients treated with newer generation devices with lower rates of need for a second valve and lower rates of residual aortic regurgitation. However, there was no difference with regards to mortality in these patients. Residual aortic regurgitation is not a benign issue. Data from the same registry indicated that patients that had moderate or more aortic regurgitation after the implantation of the transcatheter heart valve tended to have a 1-year mortality of almost 50%, whereas patients with a post-procedural mild or no aortic regurgitation had a mortality rate of 22% only. This is interesting. I think due to the absence of calcification, we are somehow tempted to aggressively oversize the device in these patients. However, this multi-center study indicated that the risk of device embolization is high in patients with relative undersizing. I think this is quite obvious, but also in patients with relative oversizing. So even if doctors tend to oversize the valve in these patients, there was a considerable risk of device embolization. And the best outcomes were in patients with neutral sizing. There was no risk, no interaction of valve sizing on residual aortic regurgitation. We have seen data mostly from non-dedicated devices. So non-dedicated devices designed for the treatment of aortic stenosis that were used for treatment of aortic regurgitation. But there are also some dedicated devices for use in patients with aortic regurgitation. The Jenna valve, for example, does have a self-expanding 19-hole stent with 3 integrated locators enabling positioning. And with the Jenna valve, you can do anatomical positioning. This means that the commissures of the prosthesis are positioned precisely on the commissures of the native valve. The Jenna valve comes with a transapical system and with a transfemoral system. And this device is currently under investigation in the Align AR trial. There's a second valve, the J valve, also a dedicated device for aortic regurgitation. It is a self-expandable porcine valve. Also comes with a transapical and transfemoral delivery system, is not recapturable, and has a support frame that is connected to 3 U-shaped anchorings. So this is corresponding to the locators in the Jenna valve. So I think the principle or the concept of this valve is very similar to the Jenna valve, and allows accurate positioning of the valve in the aortic valve complex. This slide shows a meta-analysis of 12 reports treated with patients with off-label and on-label devices, so J-valve or Jenna valve, versus other second-generation transcatheter heart valves. We see no differences with regards to mortality or stroke. However, procedural success tended to be a little bit higher in patients treated with dedicated devices as compared to newer generation devices. So in conclusion, transcatheter aortic valve replacement is an alternative to surgical aortic valve replacement in inoperable patients with aortic regurgitation. Positioning, anchoring, and sealing of contemporary TAVI devices is, however, complicated by the absence of calcification, frequent dilatation of the aortic root, and an excessive stroke volume. Newer generation devices featuring repositionability, internal skirts, external cuffs, and sleeves increase device success and are associated with low risk of residual aortic regurgitation and device malpositioning. However, I think we forgot one potentially important indication for transcatheter aortic valve replantation, and this is TAVI for rheumatic heart disease. We know that 2 out of 3 deaths from valvular heart disease worldwide are due to rheumatic heart disease and not due to degenerative valve disease. There has been some registry data on TAVI in patients with rheumatic aortic stenosis. An analysis from the United States of 605 patients undergoing TAVI for rheumatic aortic stenosis indicated comparable survival in patients with rheumatic aortic stenosis undergoing surgical aortic valve replacement or TAVI. At the same time, there was comparable survival throughout a little bit more than 1 year in patients undergoing TAVI for rheumatic aortic stenosis as compared to patients treated with TAVI for degenerative aortic stenosis. In low and middle income countries, the prevalence of non-calcific aortic regurgitation is up to 4 times higher than the prevalence of calcific aortic stenosis, and rheumatic aortic regurgitation is the underlying pathology in more than half of all patients requiring single aortic valve replacement in low and middle income countries. I think I'm not in a position to give you a lecture on the morphology of rheumatic heart disease, and you're much more experts than I am on this topic, but you know that there's some fibrinous thickening of the valve, there may be some commissural fusion, but most of all, patients tend to present either with mitral regurgitation, mitral stenosis, or aortic regurgitation, and I think aortic stenosis is a rather uncommon presentation of rheumatic heart disease. However, there have been some efforts in transcatheter aortic valve replacement for patients with rheumatic heart disease. The SAT-TAVI valve developed in South Africa, for example, is self-locating, has a non-occlusive balloon expandable system for transcatheter aortic valve implantation, and comprises a hollow balloon and stabilizing locator trunk, so very similar to the J valve and the Jenna valve. This allows for tactile placement without the need for rapid pacing. This valve has not been tested in humans yet, but in animal studies it proved very effective. So with this, to close, I think I'm looking forward to see more studies on transcatheter aortic valve replacement in patients with rheumatic heart disease, and I'm very open for your questions and comments.
Thank you so much, Thomas, for that fantastic overview of TAVI in these unusual scenarios, including pure native AR. I'm sure there are certain devices which are specifically designed for pure AR with anchoring. And what are the devices that are in research and pipeline where there is specific anchoring mechanism to be deployed in pure aortic regurgitation? And one more comment about rheumatic valve is most of these patients are relatively younger, and even though they have severe aortic stenosis, the presence of calcium might be less, might be more fibrotic. So the long-term course of these patients with a TAVI is also need to be discussed. Your comments, Thomas?
Yes, exactly. I think you're absolutely right. I mean, there are some new devices with new concepts with tactile feedback that assist in implantation, like the J-valve and the Jenna valve, and I think these devices may be also useful for the treatment of patients with rheumatic heart disease. I'm fully aware that the majority of patients is considerably younger with rheumatic heart disease, but there may be some patients, also older patients, that present with rheumatic aortic stenosis, rheumatic aortic regurgitation, that may have an absence of calcification. But even in these patients, I think it is still possible to implant a transcatheter heart valve. There are also patients with degeneration that don't have too much calcification, and they are still treated with transcatheter heart valves. I would also like to emphasize that there are some devices that are not very suitable for patients with excessive calcification. I think balloon expandable valves, they are very well suited for the treatment of patients with severe aortic severe calcification. But on the other hand, there are also devices that don't have the radial strength of a balloon expandable device, and they may be less suitable in patients with severe calcification and are more treated in patients with less calcification or even absence of calcification.
Dr. Ashish, your thoughts?
Hey, Dr. Thomas. Just a couple of questions from my side. One is, theoretically in rheumatic aortic valve disease, the incidence of or the need for pacemaker implant should be lower. Do we have any data from the registry that you showed? And number two, the lack of procedural success in the meta-analysis was close to about 40%. Now the AR was far less. So what was actually the main reason for the absence of procedural success? Is it that the embolization was far more than was reported, or were there any other factors?
Yes, so these are both two very good questions. So first, with regards to pacemaker implantation in patients with rheumatic heart disease, unfortunately, the data that we have from the United States, from the Medicare registry, didn't provide any more data other than mortality data. So we don't have any data on stroke rates, on procedural success rates. We don't have data on pacemaker implantation. It's really just about survival or death. So I think there is really need to have more data on this topic with more granularity compared to what we have seen. Still, I think this was a great start and a great initiative to show that this is possible and this may be a way for the future. On the other hand, as you pointed out correctly, device or procedural failure was very, very high in patients treated for aortic regurgitation. And this was mainly due to residual aortic regurgitation and malpositioning of the valve, which was pretty high. And therefore, even if numbers are much better in patients treated with newer generation devices that have some sort of repositionability and that do have these cuffs and skirts that mitigate rates of aortic regurgitation, I still think that TAVI for patients with aortic regurgitation is reserved for inoperable patients, and surgery is the way to go for intermediate and high-risk patients. It's really reserved for inoperable patients that don't have any other options.
Point well taken there, Dr. Thomas. Dr. Jose, any comments, newer indications for TAVI here?
Yeah, so wonderful talk, Dr. Pilgrim again. So in our experience, we do TAVI for pure AR and only patients who are inoperable, just like Dr. Pilgrim said. So in these patients, they tend to have usually very large annulus and root, and their LV is also big. And because their stroke volumes are also high, you need to pace them really high at a higher rate. So generally, if you're using a balloon expandable valve, you pace at about 200 beats per minute. And we deploy the valve, you inflate the balloon very, very slow. So you can make this fine adjustments on the go. And in general, you tend to start the deployment position a little lower than for a pure aortic stenosis. And in our experience, if you oversize by 15 to 20%, then the risk of paravalvular leaks with the balloon expandable technology is much lower than a self-expanding valve technology. So but for a balloon expandable valve, you can't oversize more than 20% because there's a chance of annulus rupture is there. But in most cases, people tend to use self-expanding technology because of this fear of annulus rupture. Regarding rheumatic cases, again, we don't see much of calcium in the leaflets, but again, balloon expandable technology is quite feasible. We have done quite a few cases with the balloon expandable technology. And the common scenario you find is most of these patients would have had a previous mechanical mitral valve, and then you have to implant the TAVI valve in such patients. So the mitral mechanical prosthesis to the aortic annulus distance becomes key in such patients for doing this cases successfully.
Indeed, it would be a paradigm shift if structural interventions would be the theme for rheumatic heart disease in third world countries like us. Dr. Bijulal, any comments and insights on this?
No, I just want to make one comment. One of the reasons for this inoperable patients is aorta arthritis. In my practice, I have seen 2 patients with aorta arthritis with associated very badly damaged, badly diseased ascending aorta, and the surgeon was not keen to go inside. So we had to do TAVI in those 2 patients. They have having pure air and aorta arthritis.
Fantastic, fantastic. I think we've had a really wonderful session here today, and I think with that we would close our session today. I would give my mic over to our course director, Dr. Shafeeq Mattummal.
Thank you, Salman. Dear friends, we had an exciting 3 days of academic sessions in different parts of interventional cardiology. We had live cases, tips and tricks, case-based lectures. We had insightful talks on research and a lot of look into innovations as well. The first faculty who accepted my invitation was Professor Lars, who is a master teacher and guide to me, and I sincerely thank you, Dr. Lars. And I thank my good friend, Dr. Thomas Pilgrim, who accepted my invitation. Actually, he was on a vacation in some part of the world. Thank you, Thomas. I thank all the expert panelists who actually generated such brilliant discussions and kept the sessions really lively. I thank all the delegates who logged in from various parts of the world in the summit, whose active participation and questioning and suggestions were actually really valuable. Special mention to our course director. On day 1, we had Dr. Professor Bahuleyan sir, and on day 2, Dr. Ashraf, whose experience and knowledge in respective field helped us to keep the scientific section very academic and edgy. And also my friends, moderators, Dr. Anil Salim and Dr. Salman Salahuddin for their complete involvement and contribution, and the way how they actually conducted and involved all panelists and speakers into very fruitful discussions. I sincerely thank the organizing team, Anand for his audiovisual team and for their help. And last but not the least, I thank Abbott and their organizational team for their brilliant efforts and work, making this summit a fantastic program. That would bring an end to our program. Thank you all so much for being with us. See you next year. Good night and see you again.
Thank you all.